Have you ever paused to truly marvel at the hidden complexities beneath the surface of the human body?
Mm,
We often think we grasp the basics, but the intricate design, the sheer elegance of how everything connects and functions, uh, it's truly
it
astounding.
really is.
Today, we're embarking on a profound deep dive into one of the most intricately designed and, well, clinically significant systems imaginable, the female reproductive tract and all its crucial, intimately connected neighbors.
Indeed. Our mission with this deep dive, really, is to equip you with the kind of knowledge that moves beyond mere facts and into true mastery. The kind that elite professionals in gynecology possess.
Right.
We'll be meticulously dissecting every detail, every nuance, and every surprising fact from our foundational anatomical text.
Yeah.
It's not just about knowing what these structures are, but deeply understanding why their specific design, their relationships, and their unique functions are so vitally important.
Like peeling back the layers.
Exactly. Think of it as peeling back the layers to see the genius of biological engineering.
That's exactly it. Whether you're preparing for a critical meeting, expanding your medical expertise, or simply driven by an insatiable curiosity, get ready for some serious aha moments.
Hmm.
We're going to break down complex ideas, make them incredibly relatable, and reveal the hidden interconnectedness that makes this entire system a true marvel. So let's unpack this incredible architecture piece by detailed piece, focusing on not just the information, but the insight behind it.
Sounds like a plan.
So let's begin at the very front door, the initial gateway, if you will, the external genitalia, more commonly known as the vulva.
Okay.
Our source describes this as an ill-defined area in gynecological practice, which immediately sparks my curiosity. What exactly are we encompassing when we use the term vulva?
That's a great starting point because that ill-defined area highlights a common challenge. In practice, the vulva encompasses the entirety of the external genitalia.
Yeah.
And for clinical convenience, it also includes the perineum.
Okay.
To get specific, anatomically, it's framed anteriorly by the mons veneris, that's the pubic mound,
Right.
laterally by the labia majora, and posteriorly by the perineum itself.
Okay.
Now, this precise anatomical knowledge isn't just for right memorization in a textbook. It's absolutely critical for accurate diagnosis, for interpreting what doctors see on ultrasound, CT, or MRI scans, and especially for surgical precision.
Yeah, you need to know where you are.
Exactly. For example, understanding these relationships is vital to avoid inadvertently injuring neighboring structures, like the bladder or rectum, during gynecological procedures.
Makes sense.
Furthermore, mastering the intricate lymphatic drainage pathways here is non-negotiable for effectively staging and treating various genital tract malignancies, ensuring that no cancerous cells are left behind.
That brings immediate clarity to why such detail matters. Speaking of the labia majora, these are the outer folds. Beyond their basic appearance, what's truly special about their anatomy and what clinical lessons do they hold?
Well, the labia majora are more than just folds of skin. They enclose a variable amount of fat, almost like padded cushions. They're actually best developed or most plump during a woman's childbearing years.
Interesting.
It's quite interesting that in children before puberty, and similarly in postmenopausal women, the amount of subcutaneous fat in the labia majora is relatively scanty, making the cleft between them more noticeable.
Right.
At puberty, the familiar pudendal hair appears, not just on the mons veneris, but also on the outer surface of the labia majora, and sometimes even extending to the perineum.
Okay.
Yet the inner surface is distinctly different. It's hairless, often moister, and a pinker hue than the outer, covered by non-keratinized squamous epithelium.
So dynamic in appearance and content, what other hidden depths do they hold?
Absolutely. They're packed with sebaceous glands, sweat glands, and of course, hair follicles. But what's truly fascinating are the specialized appendages glands also present here.
Ah, yes.
These are a type of sweat gland that produce a very characteristic individual aroma. On the clinical side, a rare tumor called hydroadenoma of the vulva actually originates from these very apocrine glands. The presence of all these structures makes the labia majora susceptible to common skin issues like folliculitis, boils, and sebaceous cysts. Their secretions also notably increase during sexual excitement.
Okay.
And for a really striking anatomical parallel, the labia majora are homologous to the scrotum. In males, they develop from the same embryonic tissue.
Right. That homology is fascinating.
What's more, these vulvar tissues are highly responsive to hormones, particularly estrogen. After menopause, due to the natural decline in estrogen, the vulvar skin can atrophy, becoming thinner and drier.
Which causes problems.
Exactly. This often leads to a condition called atrophic vulvitis, which can manifest as persistent itching. It's a clear example of how systemic hormonal changes manifest directly in localized anatomy.
That level of responsiveness is incredible. Let's move inward to the labia minora, the more sensitive inner folds. How do these compare to the majora in terms of structure and function?
Well, the labia minora are much thinner folds of skin, richly supplied with veins and elastic tissue lying just inside, or medial to, the labia majora. Unlike their outer counterparts, they are highly vascular and famously erectile during sexual activity, yet they contain no sebaceous glands or hair follicles.
Interesting difference.
Yeah. Anteriorly, they embrace the clitoris, forming both the prepuce, which is like a hood over its upper surface, and the frenulum underneath.
Got it.
Posteriorly, they join to form a delicate fold of skin called the fourchette, which is quite often, though not always, torn during childbirth.
Right.
There's also a small boat-shaped hollow just between the hymen and the fourchette, known as the fossa navicularis.
Fossa navicularis, okay.
And just as the labia majora find their male counterpart in the scrotum, the labia minora are homologous to the ventral aspect of the penis.
And at the very core of vulvar sensation, we have the clitoris. Our source highlights it as a vital erectile organ. Can you unpack that a bit more for us? What makes the structure so central, and are there any particularly surprising aspects of its anatomy or function?
The clitoris is indeed an erectile organ, profoundly important for sexual sensation. It consists of a visible glans, which is covered by the frenulum and prepuce, and a subcutaneous body extending deeper.
Okay.
It's anchored to the underside of the pubic bone by the suspensory ligament and, much like the labia, has a fascinating homology.
Yeah.
It corresponds directly to the penis in males.
Right, the homology again.
Normally, it's quite small, about 1 to 1.5 centimeters long and 5 millimeters wide. However, if it measures more than 3.5 centimeters in length and 1 centimeter in width, it's termed clitoromegaly.
Clitoromegaly?
A condition that often signals virilism due to an excess of androgen hormones.
Ah.
The clitoris is incredibly richly supplied with nerve endings, making it exquisitely sensitive. During sexual arousal and coitus, it becomes erect and plays a very significant role in inducing orgasm.
Makes sense.
Given its high vascularity, any injury to the clitoris can cause profuse bleeding and, as you can imagine, intense pain due to that nerve supply.
Moving just past the clitoris, we encounter the vestibule and the hymen, often described as thresholds of the vagina. What's the anatomy and significance of these structures, particularly in a modern context?
Right. The vestibule is the precise space nestled between the anterior and inner aspects of the labia minora, bounded posteriorly by the vaginal introitus, or opening.
Okay.
Immediately behind the clitoris, you'll find the external urethral meatus, the opening of the urethra, and just posterior to the meatus is the vaginal orifice itself, typically framed by the hymen. In virgins, the hymen is a thin membrane of squamous epithelium, generally featuring a small, off-center opening that usually doesn't allow a fingertip to pass.
Right.
Coitus traditionally results in the rupture of the hymen, creating multiple radially arranged lacerations. This rupture can sometimes cause brisk hemorrhage, which is why it's a clinically relevant detail.
Okay.
Further lacerations, often more extensive, occur during childbirth, after which the hymen is represented by small, irregular skin tags known as carunculae myrtiformis.
Correct.
Exactly. Now, for the modern context, and a crucial point to understand, with the widespread use of internal sanitary tampons, the integrity of the hymen is no longer considered a reliable indicator of virginity.
That's a really important point.
It is. This piece of anatomical knowledge has evolved significantly in its social and clinical interpretation.
And finally, a key player in natural lubrication, Bartholin's gland. Our source mentions it's normally impalpable, but palpable when inflamed. Why is that?
Well, Bartholin's gland is strategically located posterolaterally to the vaginal orifice, nestled deep to the bulbospongiosus muscle, and superficial to the outer layer of the triangular ligament.
Okay.
It's actually embedded in the erectile tissue of the vestibular bulb at its very posterior extremity. The reason it's normally impalpable is its small size. It's roughly 10 millimeters in diameter.
Huh, quite small.
Yeah. However, when it becomes inflamed, typically due to infection, it swells, becoming readily felt between the finger and thumb, often causing significant discomfort. This gland has a remarkably rich vascular bed, which accounts for the brisk bleeding that always accompanies its surgical removal.
Wow.
Its duct is quite long, about 25 millimeters, and travels forwards and inwards to open just external to the hymen on the inner side of the labium minus. It's a compound racemose gland, meaning it has a branching structure,
Right.
with its secretory achini lined by low columnar epithelium. The duct's epithelium transitions from cubical near the achini through transitional and finally to squamous near its mouth.
Interesting transition.
Its primary and vital function is to secrete lubricating mucus during sexual arousal and coitus. Clinically, Bartholin's gland and its duct are a common site of infection, particularly in acute gonorrhea, where the reddened mouth of the duct can be visibly distinguished.
Ah, so you can actually see the inflammation.
Sometimes, yes. You might often hear about a Bartholin's abscess in clinical settings, which is a painful collection of pus resulting from such an infection, sometimes requiring drainage.
Having explored the intricate outer design, let's now venture inwards into the dynamic internal passages. First, the fibromuscular tube that acts as both a pathway and a protector, the vagina. What's its fundamental structure and its directional path within the pelvis?
Okay, the vagina. It's essentially a fibromuscular passage connecting the uterus above to the introitus, or opening below. Its lower end sits at the level of the hymen and is encircled by the erectile tissue of the bulb, which, in a fascinating parallel, corresponds to the corpus spongiosum in males.
Right, another homology.
Exactly. Within the pelvis, the vagina itself lies approximately parallel to the plane of the brim of the true pelvis, with a gentle forward curve as it descends. Typically, its anterior and posterior walls are in close contact.
Okay.
It's not a uniformly cylindrical tube. It's nearly twice as wide or capacious, in its upper part giving it a somewhat flask-like shape.
Flask-like, interesting.
Yeah. The vaginal portion of the cervix actually projects down into its upper end, creating 4 distinct pockets or recesses called the fornices, an anterior, a posterior, and 2 lateral ones.
So those fornices, their depth isn't static then. Does it vary by life stage?
Precisely. The depth of these fornices is highly dependent on the development of the cervical portion that projects into the vagina. In prepubertal girls and in postmenopausal women, where the uterus and cervix have undergone natural atrophy, the fornices are quite shallow.
Makes sense.
Conversely, in women born with a congenital elongation of that vaginal portion of the cervix, the fornices can be remarkably deep.
Wow.
Because the vagina attaches to the cervix at a slightly higher level posteriorly, the posterior vaginal wall is notably longer than the anterior, about 11.5 centimeters versus 9 centimeters.
Significant difference.
It is. This anatomical difference also makes the posterior fornix the deepest of all the fornices, which is a key clinical point for certain procedures.
And what about the internal architecture of the vaginal walls? Are those transverse folds you mentioned earlier constant?
Well, in women who haven't given birth, known as nullipari, the vaginal walls feature distinct transverse folds, or rugae.
Rugae, right.
These folds are incredibly important because they allow the vagina to stretch and dilate significantly both during sexual intercourse and especially during childbirth.
Crucial for elasticity.
Absolutely.
Right.
However, in women who have had multiple children, these folds become partially or even largely obliterated. On the anterior vaginal wall specifically, clinicians can distinguish 3 subtle but important sulci, or grooves.
Okay.
The submetal sulcus, found just above the external urethral meatus, about 35 millimeters above that, the transverse vaginal sulcus, which broadly corresponds to the junction between the urethra and the bladder, and further up the bladder sulcus, marking the interface where the bladder meets the anterior vaginal wall. These seemingly minor details are actually crucial landmarks for surgeons.
Fascinating how detailed the anatomy gets. And the lining of the vagina, is it unique in its composition and responsiveness?
It's quite unique, yes. The vaginal mucosa is lined by non-keratinized squamous epithelium. This isn't just a simple layer. It's comprised of a basal layer of cuboidal cells, a middle layer of prickle cells, and a superficial layer of cornified cells.
Prickle cells.
Interestingly, in newborns, this epithelium starts out almost transitional in nature, with very few cornified cells, and only fully develops its mature squamous character around puberty.
Okay.
A key point is that no glands open directly into the vagina. Its natural lubrication is derived partly from mucus produced by the cervix and partly from a process called transudation.
Transudation.
Yeah, where fluid seeps directly through the vaginal epithelium. Beneath this epithelium lies a subepithelial layer that is highly vascular, containing a lot of erectile tissue, which contributes to its responsiveness during arousal.
Right.
External to this is a muscle layer, a complex interlacing lattice of smooth or plain muscle with larger blood vessels running through the surrounding connective tissues.
This epithelial lining sounds highly responsive, particularly to hormones. What are the clinical ramifications of that sensitivity?
It absolutely is, and this sensitivity has profound clinical implications. For example, in a truly unfortunate historical context, if a female fetus was exposed to diethylstilbestrol, or the
Yes, they're
synthetic estrogen taken by some mothers during pregnancy in past decades, the vaginal mucosa in the upper two-thirds could abnormally develop columnar epithelium instead of squamous. This carried a significant risk for the daughter to develop vaginal adenosis and even vaginal cancer in adolescence.
That's
It
terrible.
really was. Also, when the vaginal walls prolapse, meaning they descend and protrude outside the body, the exposed mucosa can undergo keratinization.
Keratinization.
Yeah, it literally starts to look and feel more like skin, turning a brownish color, and can develop decubitus ulcers, which are pressure sores. And of course, menopause, with its dramatic drop in estrogen, leads to significant atrophy of the vagina, making the tissues thinner and drier. These are all clear demonstrations of the direct link between hormonal environment and anatomical health.
So the vaginal environment is incredibly dynamic. Tell us about its natural secretions and their vital role in maintaining health and preventing infection.
Okay, so the healthy vaginal secretion is typically small in volume and appears as a white, slightly coagulated material. Microscopically, it's primarily composed of squamous cells shed from the vaginal lining and a very important microorganism, Daughter-Lane's bacilli.
Daughter-Lane's bacilli.
Yes, this is a large gram-positive rod-shaped bacterium that thrives anaerobically in an acidic environment. And that acidity is key.
Right, the pH.
Exactly. The vaginal pH averages around 4.5 during the reproductive years, and this acidity, primarily due to lactic acid, is a powerful natural defense, inhibiting the growth of most pathogenic organisms.
Like a protective barrier.
It is. And this acidity is unequivocally estrogen dependent. After menopause, without sufficient estrogen, the pH naturally rises to neutral or even alkaline. Similarly, before puberty, the pH hovers around 7.
Okay.
This higher pH in both prepubertal girls and postmenopausal women explains why they are more susceptible to mixed organism infections, as the protective acidic barrier is compromised.
So that acidity is a crucial protective mechanism, and it's intrinsically tied to estrogen levels.
Exactly. The lactic acid synthesis is essentially a product of the enzymatic or bacterial activity, specifically Daughter-Lane's bacilli, acting on the glycogen present in the vaginal epithelial cells.
Ah, the glycogen.
And that glycogen itself is estrogen dependent. So if there's insufficient lactic acid activity, it can actually be boosted by administering oral or local estrogen.
Interesting.
During the puerperium, the period immediately after childbirth, or in conditions causing excessive discharge like leukorrhea, vaginal acidity is naturally reduced, creating a more hospitable environment for pathogenic organisms to survive and proliferate.
Right, which leads to problems.
Which leads us to clinical tests like Schiller's test. The squamous cells of the vagina and cervix, when healthy, contain glycogen and will stain a deep brown with iodine solution, indicating a positive test.
Positive is brown.
Right. In postmenopausal women, due to the absence or very low levels of these glycogen-containing superficial cells, Schiller's test will be negative. Critically, abnormal or malignant cells also lack glycogen, so they too will not take up the stain.
So they stay pale.
Exactly. This principle also applies when clinicians use acetic acid. Abnormal cells, due to protein coagulation, turn white, which helps guide precise biopsies for cancer detection.
And the direct hormonal influence on the vaginal epithelium itself?
Well, estrogen specifically promotes the proliferation of those glycogen-containing superficial cells, which are vital for maintaining acidity. Progesterone, on the other hand, primarily causes the proliferation of intermediate cells.
Different
effects. The absence of these hormones, as seen in a menopausal woman, means only the basal cells remain, leading to a significantly thinned and more fragile vaginal mucosa. This is why postmenopausal women can experience vaginal dryness and discomfort.
Moving on from the vagina's internal structure, let's talk about its incredibly intimate connections to neighboring organs. What are its anterior relationships?
Okay, anteriorly, the vagina have very close but distinct relationships. In its lower half, it's intimately connected to the urethra and the paraurethral glands, also known as Skene's tubules.
Skene's tubules, right.
They're so thoroughly fused here by the urethrovaginal fascia that sharp dissection is required to separate them surgically.
Tough separation.
Yeah. However, in its upper half, the vagina is related to the bladder, specifically in the region of its trigone. Here, the fascial layers of the vesical and vaginal fascia are much more loosely connected and can be easily separated by blunt dissection, creating what surgeons call the vesicovaginal space.
Ah, the vesicovaginal space.
It's absolutely crucial to note that there's considerable vascular and lymphatic intercommunication between the bladder and vaginal vessels in this area. This close relationship carries significant implications in the surgery of malignant diseases, as it provides potential pathways for cancer spread.
That makes perfect sense for understanding disease progression. What about the posterior relationships? Our source specifically highlights the pouch of Douglas here.
Posteriorly, the vagina is layered in its relations. Its lower third is directly related to the perineal body, a crucial anatomical structure we'll build into later.
Okay.
The middle third lies against the ampulla of the rectum, and the upper third is closely related to the anterior wall of the pouch of Douglas, which in most cases contains loops of both large and small bowel.
Right, the pouch of Douglas.
This peritoneal partition, separating the vagina from the abdominal cavity, is actually the thinnest area of the entire peritoneal surface.
The thinnest, wow.
Yeah. This makes it a strategically important site. It's often chosen for painting and opening pelvic abscesses or for the development of hernias, specifically an enterocele, where bowel descends into this space.
Enterocele. Yeah.
It's also an ideal, relatively safe site for a procedure called colpocentesis, which is used to diagnose ectopic pregnancies by sampling fluid in the pouch.
So the pouch of Douglas is a really significant landmark. Can you elaborate on its precise boundaries and why that's important for clinicians?
Absolutely. The pouch of Douglas is a peritoneal cul-de-sac, essentially a blind-ended pouch of peritoneum located in the rectovaginal space deep within the pelvis.
Cul-de-sac, got it.
It's bounded anteriorly by the peritoneum, covering the posterior vaginal wall, and posteriorly by the peritoneum covering the sigmoid colon and the rectum.
Yeah.
Laterally, its boundaries are defined by the uterosacral ligaments, and its floor is formed by the reflection of the peritoneum itself. Clinically, this anatomical space is incredibly important. Endometriotic nodules, which are deposits of uterine lining tissue outside the uterus, and metastatic growths from ovarian cancer, are very frequently felt as palpable masses or nodules within the pouch of Douglas during a pelvic exam.
So key for diagnosis.
Very key. Similarly, pelvic inflammatory masses, often from infections, can also be detected here. And, significantly, the uterosacral ligaments themselves can become thickened and nodular in cases of advanced cervical cancer, which is why a thorough examination of this specific area is absolutely vital for accurate staging.
Given its central location, the vagina's lateral relations must also be quite complex.
They are indeed, and understanding them is like mapping a dense city. From below upwards, the lateral relations include the cavernous tissue of the vestibule, which is erectile tissue, then the superficial muscles of the perineum, and then the triangular ligament, a key support structure. Approximately 2.5 centimeters up from the introitus, you encounter the levator ani muscles, which form the bulk of the pelvic floor.
Right, the main support.
Lateral to these muscles lies the ischiorectal fossa, a fat-filled space. Above the levator ani, you find the endopelvic cellular tissue, a loose connective tissue, and its important condensation on either side is called Mackenrod's ligament, or the cardinal ligament, a primary uterine support.
Mackenrod's ligament.
And here's a critical detail for surgeons. The ureter, the delicate tube carrying urine from the kidney to the bladder, traverses this tissue within a protective space called the ureter canal.
The ureter canal, okay.
This canal is strategically located about 12 millimeters anterolateral to the lateral fornix, a landmark surgeons must meticulously identify to prevent injury during procedures.
And superiorly, where the vagina intimately meets the uterus, what are the key connections?
Superiorly, the cervix with its four surrounding fornices is intimately related to several crucial structures. These include the uterine vessels, Mackenrod's ligament, and importantly, the ureter.
The ureter again.
Posteriorly, wrapping around the pouch of Douglas, lie the uterosacral ligaments. These are palpable structures on vaginal examination, especially if they are thickened and nodular, which can be a sign of conditions like endometriosis or, more concerningly, advanced cervical cancer.
Here's where it gets really interesting. The squama-columnar junction, also known as the transformation zone.
Oh, yes.
Our source highlights this as a critical site, particularly in the context of malignancy. What is it about this specific area that makes it so significant, and why is it so vulnerable?
This transformation zone is truly a biological hotspot. It's a narrow dynamic area, typically 1 to 10 millimeters wide, where the delicate single-layered columnar epithelium of the endocervix, or the inner cervical canal, meets and transitions into the tougher, multi-layered squamous epithelium that lines the outer cervix and vagina.
So a meeting point of two different tissues.
Exactly. What makes it critical is the constant cellular activity happening here. as one cell type tries to convert into another. This makes these cells highly sensitive and vulnerable to irritants, mutagens, and particularly to viral agents like the human papillomavirus, especially types 16 and 18.
HPV, right?
When these agents attack, they can cause specific nuclear changes in the cells, leading to what's called dysplasia abnormal cell growth, and ultimately carcinoma of the cervix, which is unfortunately a very common malignancy in many parts of the world, including India.
So understanding the changes in this zone is fundamental for detecting early signs of cancer. Does its physical location within the cervix change throughout a woman's life?
It absolutely does, and its shifting location is a key factor in screening. In the embryonic stage, columnar epithelium initially covers the external os, the opening of the cervix.
Okay.
But after puberty, under the powerful influence of estrogen, a process called metaplasia occurs, where the columnar cells begin to transform into squamous cells, pushing this transitional zone closer to or even outside the external os.
Metaplasia.
Yeah. In a very specific, tragic historical context, in women exposed to DES in utero, this zone could be located unusually far outside the os, sometimes even spreading over the vaginal vault.
Wow.
Conversely, in menopausal women, as estrogen levels drop and the cervix naturally shrinks, this squamocolumnar junction retracts and gets indrawn inside the us.
So harder to see.
Much harder to see. This makes it much less accessible for visual inspection and explains why pap smears can have a higher false negative rate in older women.
Okay.
In stark contrast, during pregnancy and with the use of oral contraceptives, hormonal influences cause this junction to pout out from the os, making it well exposed and easier to sample.
That dynamic nature must directly impact how effective screening methods like pap smears are.
Precisely. During the reproductive years, when this junction is typically well outside the external os, it's the primary area meticulously scraped for cytology in cervical cancer screening programs.
Right, the pap smear target.
Exactly. Pap smears are actually most accurate, yielding the clearest cytological findings during pregnancy because the external os naturally dilates a bit, and the squamocolumnar junction is beautifully exposed all around.
Good to know.
For menopausal women, to improve the efficacy of pap smear cytology, clinicians can strategically administer local or oral estrogen, or even use a prostaglandin E. pessary to encourage this junction to pout out again, making it more accessible.
So you can help expose it.
You can. When a pap smear does show abnormal cells, this squamocolumnar junction is then intensely scrutinized using a colposcope, a magnified view of the cervix, and any suspicious areas are carefully biopsied to detect cancer. This is a perfect example of how anatomical understanding directly informs the life-saving screening and diagnostic process.
Let's turn our attention now to the central organ of reproduction, the uterus. What are its basic shape, size, and how is it anatomically divided?
Okay, the uterus. A truly remarkable organ, best described as pyriform or pear-shaped.
Pear-shaped.
It typically measures around 9 centimeters in length, 6.5 centimeters in width, and 3.5 centimeters in thickness, weighing about 60 grams, which is roughly 2 ounces.
Okay.
Anatomically and functionally, it's clearly divided into two main parts: the body, or corpus, and the cervix. The internal os, an internal opening, marks the line of division where the mucous membrane lining the uterine cavity seamlessly becomes continuous with that of the cervical canal.
The internal os key landmark.
Very key. At this very level, the peritoneum covering the front of the uterus dramatically reflects onto the bladder. And notably, the powerful uterine artery, after traversing transversely across the pelvis, reaches the uterus precisely at the internal os, where it makes a sharp right-angle turn and ascends vertically along its lateral wall.
Ah, right at that level.
Exactly. The cervix itself is further divided into a vaginal portion and a supravaginal portion. Finally, the fundus of the uterus is simply the topmost part of the corpus uteri, lying above where the fallopian tubes insert. The uterine cavity itself is triangular, with a modest capacity of about 3 milliliters.
Only 3 milliliters small.
Pretty small when not expanded. Its lower angle is the internal os, and its lateral angles, where it connects to the fallopian tubes, are called the cornual ends.
And what about its direct connection to the peritoneal cavity? That sounds unique for an internal organ.
It is indeed a unique and clinically significant continuity. The uterine cavity communicates directly with the openings of the fallopian tubes. These tubes, in turn, open into the peritoneal cavity, the main body cavity, via their abdominal ostia.
So a direct pathway outside.
Yes, essentially. This means there's a direct, albeit tiny, passage from the external environment through the vagina and uterus and into the normally sterile peritoneal cavity. This continuity is how both spermatozoa travel to meet the egg and how the fertilized ovum then travels back to the uterus.
And also route for infection.
Unfortunately, yes. This also makes the female reproductive tract a potential pathway for sending infections into the pelvic cavity. The wall of the uterus is composed of three distinct layers. The outermost peritoneal covering, called the perimetrium, the thick, muscular middle layer, the myometrium, and the innermost mucous membrane, the endometrium. The uterus is remarkably capable of distension, as dramatically seen during pregnancy, or in pathological conditions like hematometra where blood collects, or even when distended with media during a hysteroscopic examination.
Right.
When not distended, its two walls usually lie in close apposition.
You mentioned the peritoneal covering is incomplete. Can you elaborate on how that affects its anatomy?
Yes, the peritoneal covering of the uterus isn't a complete wrap. Anteriorly, the entire body of the uterus is covered by peritoneum. But this peritoneum then reflects forward onto the bladder at the level of the internal os.
Okay.
This means the cervix itself has no anterior peritoneal covering, which is a key surgical consideration.
Right, important for surgery.
Very. Posteriorly, the whole body of the uterus is covered by peritoneum, as is the supravaginal portion of the cervix. The peritoneum then sweeps downwards and reflects from the supravaginal cervix onto the posterior vaginal wall, forming the deepest part of the posterior fornix.
Okay.
Laterally, the peritoneal covering is also incomplete due to the direct insertions of the fallopian tubes and the round and ovarian ligaments into the uterus. Below this level, the two sheets of peritoneum that form the broad ligament leave a thin, bare area laterally on each side of the uterus. This detailed understanding of peritoneal reflections is crucial for safely performing gynecological surgery.
So the myometrium, that thick muscle layer, is truly the powerhouse. How does its structure contribute to its incredible function, especially in childbirth?
The myometrium is indeed the heart of the uterus's power. In the cervix, this muscle tissue is densely interwoven with a large amount of fibrous tissue and collagen, giving the cervix its characteristic firm, consistent feel. The muscle fibers here aren't arranged in an orderly fashion.
Right, more fibrous in the cervix.
That's exactly. However, in the main body of the uterus, the myometrium is substantially thicker, about 10 to 20 millimeters, and you can discern three distinct layers, although they are most prominent and functionally crucial in the pregnant impurple uterus.
What are those specific layers and their functions?
Okay, the external layer, which lies just beneath the peritoneum, is thin and composed of longitudinal fibers. These fibers essentially sweep from the anterior cervix over the fundus and down to the posterior surface of the cervix.
Longitudinal, okay.
In a non-pregnant uterus, it's quite thin and hard to identify. Its primary function is a detrusor action, helping to expel the fetus during labor.
Expulsion.
The middle layer is the thickest and most vital. It consists of bundles of muscle separated by connective tissue, the amount of which varies significantly with age. It's most abundant during the childbearing years, particularly pregnancy, and much less so before puberty or after menopause.
Okay.
These muscle bundles are remarkably interlacing, almost like a complex weave. This interlacing is critical because the main blood vessels supplying the uterus are embedded within this connective tissue. So when these muscle cells contract, they effectively constrict the blood vessels.
Ah, the living ligatures.
That's exactly right. This layer serves a dual profound purpose. It's partly hemostatic, acting as the living ligatures of the uterus, crucial for controlling bleeding in the third stage of labor after the baby and placenta are delivered. And it's partly expulsive, contributing immense power to push the fetus out.
So both stopping bleeding and pushing.
Correct. Inefficient contraction and retraction of these specific muscle fibers are a common cause of prolonged labor and, more critically, atonic postpartum hemorrhage, a life-threatening complication.
Right, PPH.
Finally, the inner muscle layer consists of circular fibers. This layer is never as well marked as the others, but is most prominent around the internal us and at the openings of the fallopian tubes, suggesting a sphincteric or valve-like action.
Sphincteric.
Anatomically, the myometrium is thickest at the fundus, about 1 to 2 centimeters, and thinnest at the cornual end, only 3 to 4 millimeters. This thinness at the cornual end is why extreme caution is necessary during procedures like curettage or endometrial ablation to avoid perforating the uterine wall.
Good point.
As for the endometrium, the inner lining, its specific histology and how it differs from the endocervix is a deep dive in itself, detailed in specialized texts on cellular structure.
Let's transition to the cervix itself, its structure, vital functions, and unique vulnerabilities. It's often described as spindle-shaped, right?
Yes, the cervix has a distinct spindle shape and measures about 2.5 centimeters or slightly more in length. It's bordered above by the internal os, which connects to the uterine cavity, and below by the external os, which opens into the vagina.
Internal and external os.
Its mucosal lining, known as the endocervix, is unique because it lacks a submucosa, unlike the uterine body. The endocervix is lined by a single layer of tall, columnar ciliated epithelium. These cells have spindle-shaped nuclei near their base, abundant cytoplasm, and produce mucin.
Ciliated, okay.
What's fascinating is that the cilia on these cells are consistently directed downwards towards the external os. The glands within the endocervix are of the racemose type, meaning they have a complex, branching structure, and they secrete an alkaline mucus with a pH of 7.8.
Alkaline, interesting contrast to the vagina.
Yes, quite alkaline, rich in essential components like fructose, glycoprotein, mucopolysaccharide, and sodium chloride.
That sounds like a very specific, almost tailored composition for the cervical mucus. What are its critical functions?
The functions are incredibly sophisticated and vital for both reproduction and protection. The high fructose content makes it attractive and serves as a vital nutrient source for ascending spermatozoa.
Food for sperm.
Pretty much. The secretion also forms a crucial plug of mucus within the cervical canal, acting as a physical barrier that helps hinder ascending infections from the vagina into the uterus.
The mucus plug, right.
Clinically, in gonococcal and chlamydial infections, the organisms often specifically collect and hide within the crypts, the tiny folds and recesses of these cervical glands.
Hiding places.
In women who haven't given birth, the external os is typically circular. But after a vaginal delivery, it transforms into a distinctive transverse slit, which is a telltale sign of a parous cervix.
Change of shape after birth.
Structurally, the cervix is composed of significantly more fibrous tissue and collagen than muscle fibers, only about 10% muscle fibers overall, a stark contrast to the uterine body, which is about 70% muscle.
Big difference.
Huge. Microscopic examination reveals that muscle fiber percentages decrease dramatically, from 29% in the upper third to a mere 6% in the lower third. This abrupt change from the fibrous, rigid cervix to the muscular, contractile body is truly remarkable.
Yeah.
As pregnancy progresses, particularly in late pregnancy and at term, prostaglandins induce a process where an enzyme called collagenase dissolves the collagen in the cervix into a fluid form, rendering the cervix soft and stretchable for labor.
So it prepares for birth chemically.
It does, it ripens.
And what are the key functions of these specialized endocervical cells that make them so important for reproductive health?
Well, these cells have a multifaceted role. First, those cilia, directed downwards, actively help prevent ascending infection from reaching the uterus. Second, they act as a biological sieve, filtering out abnormal spermatozoa and ensuring that primarily healthy, viable ones are allowed to enter the uterus.
Like quality control.
Exactly. Third, the cervical mucus provides crucial nutrition to the spermatozoa as they traverse the cervical canal. And fourth, it facilitates the capacitation of sperms.
Capacitation.
Yes, a subtle but essential process that enables them to gain the ability to fertilize an egg. From a structural and function perspective, the body of the uterus and the cervix are fundamentally distinct. The cervical epithelium, unlike the uterine lining, does not undergo periodic alterations during the menstrual cycle.
Stays relatively stable.
Right. And the decidual reaction pregnancy, where the uterine lining dramatically transforms, is only rarely seen in the cervix. Furthermore, uterine malignancy typically presents as an adenocarcinoma of the endometrium, while cervical carcinoma is usually a squamous cell growth known for its high malignancy potential, underscoring the different cell types and their vulnerabilities.
Our source also highlights the isthmus as an intermediate zone. What's its specific role, particularly as pregnancy progresses?
The isthmus is a small but critical intermediate zone, roughly 6 millimeters in length, situated precisely between the endometrium of the uterine body and the mucous membrane of the cervical canal.
The transition zone again?
Sort of, yeah. Its epithelial lining resembles and behaves like the endometrium of the uterine body. During pregnancy, this isthmic portion undergoes remarkable stretching, dramatically expanding to form the lower uterine segment in late pregnancy.
The lower uterine segment, okay.
It's less contractile during pregnancy and labor compared to the more muscular uterine body, but it stretches further under the powerful force of uterine contractions. Surgeons identify it during a cesarean delivery by a characteristic loose fold of peritoneal lining covering its anterior surface, a clear anatomical landmark.
It sounds like the cervix to corpus ratio is also an important indicator, almost a biological clock, reflecting age and hormonal status.
It absolutely is a fascinating indicator of developmental stage and hormonal milieu. The relationship between the length of the cervix and that of the uterine body changes significantly throughout a woman's life.
Okay.
Before puberty, the cervix to corpus ratio is approximately 2.1, meaning the cervix is proportionally much larger.
So it's dominant initially.
Right. At puberty, under hormonal shifts, this ratio dramatically reverses to 1.2. During the reproductive years, the cervix to corpus ratio continues to shift, becoming 1.3 or even 1.4, with the body of the uterus becoming proportionally much larger to accommodate pregnancy.
Uterus takes over.
After menopause, the entire organ undergoes atrophy, a natural shrinkage, and the portio vaginalis of the cervix, the part that projects into the vagina, may eventually disappear entirely.
And the quality and quantity of cervical secretion also changes, right? What does that tell us about a woman's cycle and even potential for fertility?
Yes, while endometrial secretion is typically scanty, cervical secretion is abundant, and its quality and quantity change dramatically throughout the menstrual cycle, directly influenced by fluctuating hormone levels.
Hormones drive the changes.
Definitely. This mucus is incredibly rich in fructose, glycoproteins, and mucopolysaccharides. The fructose, as we mentioned, is vital for nourishing sperm as they journey through the cervical canal. Under the influence of estrogen during the preovulatory phase, the glycoprotein network within the mucus becomes organized in parallel, like a series of parallel tracks, which greatly facilitates sperm penetration.
Opening the gates.
Exactly. However, under progesterone secretion, which dominates after ovulation, this network transforms, forming interlacing bridges that effectively prevent sperm entry into the cervical canal.
Closing the gates.
Right. This precise property of progesterone is actually exploited in many contraceptive pills and progesterone-impregnated intrauterine contraceptive devices, making the cervix inhospitable to sperm.
Clever use of physiology.
It is. During ovulation, a specific change occurs. The sodium chloride content in the mucus increases dramatically, and when a drop of this mucus is dried on a slide and examined under a microscope, it forms a distinctive fern-like pattern, a classic clinical sign used to indicate ovulation.
The ferning pattern, right.
Yeah.
Let's move on to the position of the uterus itself. It's normally described as being in a position of anteversion and anteflexion. What exactly do those terms mean, and why is this normal position significant?
Right, this normal position is a beautifully balanced act. Anteversion refers to the angle of the entire uterus relative to the axis of the vagina. In anteversion, the axis of the cervix is directed downwards and backwards, which means that on a vaginal examination, the anterior lip of the cervix is felt as the lowest part.
Okay, anteversion is the overall tilt.
Anteflexion means the body of the uterus is bent forward on the cervix, roughly at the level of the internal os.
And anteflexion is the bend.
Exactly. So in combination, the uterus is generally tipped forward and also bent forward on itself. This overall forward inclination, or anteflexion, is crucial because it means the body of the uterus rests directly against the bladder.
So its position has a direct practical relationship with other pelvic organs like the bladder.
Precisely. As a direct consequence of its normal anteflexion, the body of the uterus lies intimately against the bladder. The peritoneal pouch that separates the bladder from the uterus is called the uterovesical pouch.
Uterovesical pouch.
The peritoneum, the lining of the abdominal cavity, reflects from the front of the uterus directly onto the bladder at the level of the internal os. Posteriorly, we find a large peritoneal pouch positioned between the uterus and the rectosigmoid colon.
The posterior pouch.
If the uterus is gently pulled forwards during an examination, you can sometimes visualize two distinct folds of peritoneum passing backwards from the uterus to meet the parietal peritoneum, which lines the pelvic sidewall lateral to the rectum. These are the uterosacral folds.
Uterosacral folds?
They lie at the level of the internal os and pass backwards and upwards. Within these uterosacral folds, but at a slightly lower anatomical level, lie the uterosacral ligaments, which are important condensations of the pelvic cellular tissues, a complex network of supporting structures we'll explore soon.
And the pouch of Douglas, that key peritoneal space, is again defined by these structures, highlighting its anatomical importance.
Yes. The pouch of Douglas is the crucial peritoneal pouch situated just below the level of those uterosacral folds. It's elegantly bounded anteriorly by the peritoneum covering the upper part of the posterior vaginal wall, and posteriorly by the peritoneum covering the sigmoid colon and the upper end of the rectum.
Boundaries are key.
The posterior fornix of the vagina, the deepest recess, lies in incredibly close relation to the peritoneal cavity. It's separated by only the posterior vaginal wall and a single thin layer of peritoneum.
Very thin separation.
Very thin. This close proximity means that if there's a collection of pus within the pouch of Douglas, it can be relatively easily evacuated by a surgeon by making an incision in the vagina in the region of the posterior fornix.
Right, easier access posteriorly.
Yes. Conversely, trying to access the uterovesical pouch from the vagina is far more challenging. You require incising the vagina, then carefully separating the bladder from the cervix and navigating through the vesicocervical space before finally reaching that uterovesical fold of peritoneum. These anatomical nuances are critical for precise surgical planning.
We're now moving on to the appendages and neighboring organs, which form a complex and fascinating network. Let's start with the uterine appendages, specifically the broad ligaments, which sound like a central supporting structure.
They absolutely are central. The uterus itself projects upwards into the peritoneal cavity, and on each side it carries two folds of peritoneum, think of them like wide drapes, that extend laterally to the pelvic wall. These are what we call the broad ligaments.
Like wings.
Kind of like wings, yeah. The fallopian tubes, those delicate conduits of life, pass outwards from the uterine cornua, the upper corners, and lie snugly within the upper border of these broad ligaments. Slightly below the fallopian tubes, two other crucial ligaments, the ovarian ligaments posteriorly and the round ligaments anteriorly, also pass into the uterine cornua.
Okay.
Both of these, along with the fallopian tubes, are elegantly draped in peritoneum, forming part of this complex broad ligament structure.
Let's delve into the round ligament first. It sounds like it has a rather fascinating anatomical journey.
It does indeed have quite the journey. The round ligament originates from the uterine cornua and then travels beneath the anterior peritoneal fold of the broad ligament to reach the internal abdominal ring.
Internal ring.
Along this portion of its course, it's typically curved and lies just beneath the peritoneum, which makes it easily identifiable for surgeons. From there, the round ligament descends down the inguinal canal, ultimately ending by becoming adherent to the skin of the labia majora.
All the way to the labia majora.
All the way. These ligaments are composed of both smooth or plain muscle and connective tissue, and they can vary quite a bit in thickness. They actually undergo hypertrophy, meaning they significantly increase in size during pregnancy, and are generally much better developed in women who have had multiple children compared to those who haven't.
Grows during pregnancy.
Yeah. Interestingly, they can become remarkably hypertrophied, sometimes reaching a diameter of up to 1 centimeter, especially in the presence of large uterine fibroids.
So it's not just a simple static structure. It actively responds to physiological changes. And you mentioned a developmental link.
Yes, it has a deep developmental link. Embryologically, the round ligaments correspond to the gubernaculum testis in males,
Gubernaculum testis.
the structure that guides the descent of the testicles. They are also morphologically continuous with the ovarian ligaments. This continuity exists because, during intrauterine life, the ovarian and round ligaments were originally a single, continuous structure connecting the lower pole of the primitive ovary down to the inguinal canal.
Fascinating origin.
Functionally, the round ligaments are typically quite lax, and except during the intense pressures of labor, they remain free of tension. Despite their connection to the uterus, there's actually no strong evidence that their contraction alone is responsible for maintaining the normal, anti-flexed and anaverted position of the uterus.
Not the main support for position, then.
Not primarily, no. However, in cases where the uterus is pathologically retroverted, meaning tilted backwards, these ligaments can be surgically shortened or attached to the anterior abdominal wall to help bring the uterus into a more anteverted position.
So used in corrective surgery.
Sometimes. The round ligaments receive their blood supply from a branch of the ovarian artery, which connects via an anastomosis with the uterine artery. This connection is why it's necessary to ligate or tie off the round ligament during a hysterectomy.
Need to ligate it.
And importantly, lymphatic vessels from the fundus of the uterus, the very top part, travel along the round ligament, connecting with the lymphatics that drain the labium majus into the inguinal glands. This lymphatic pathway is clinically significant as it explains the possibility of cancer cells from advanced endometrial cancer of the fundus metastasizing to these inguinal glands.
Explains inguinal spread from the fundus.
Exactly.
And what about the ovarian ligaments themselves?
The ovarian ligaments pass upwards and inwards from the inner poles of the ovaries to reach the cornua of the uterus, just below where the fallopian tubes attach. They lie nestled beneath the posterior peritoneal fold of the broad ligament and typically measure about 2.5 centimeters in length.
Okay.
Like the round ligaments, they are composed of plain muscle fibers and connective tissue, but they're generally less prominent because they contain less muscle tissue. Morphologically, they are considered a continuation of the round ligament, reinforcing that shared developmental origin.
And then there's the infundibulopelvic ligament, which also sounds important.
Yes, the infundiculopelvic ligament, also known as the suspensory ligament of the ovary, is a crucial portion of the broad ligament that extends from the infundibulum, the funnel-shaped end of the fallopian tube, to the lateral pelvic wall.
Suspensory ligament.
It's incredibly important because it encapsulates and protects the vital ovarian vessels, lymphatics, and nerves that supply the ovary, a critical clinical point. The ureter, that delicate tube from the kidney, runs in very close contact with this ligament and can be inadvertently damaged during its clamping and surgery, so surgeons must exercise extreme caution.
Ureter, danger zone again.
Another one, yes. Another structure is the mesovarium, a thin mesentery that attaches the ovary to the posterior fold of peritoneum of the broad ligament, and it contains the ovarian vessels, lymphatics, and nerves specific to the ovary.
Mesovarium.
And finally, the mesosalpinx is the portion of the broad ligament that lies between the fallopian tube and the ovary. This area contains the anastomotic vessels that connect the ovarian and uterine blood supplies, as well as fascinating vestigial structures, remnants of the Wolffian body, and duct from embryonic development.
Mesosalpinx, okay.
Essentially, the broad ligament is far from simple. It's a highly complex and vital structure containing a whole host of critical elements, from the fallopian tube and various ligaments to vestigial structures, blood vessels, nerves, and even pelvic lymphatic nodes.
Let's talk about the fallopian tubes themselves, truly the conduits of life. How are they structured, and what are their key dimensions?
Okay, the fallopian tubes. Each fallopian tube is attached to the uterine cornu and then extends outwards and backwards within the upper part of the broad ligament. It typically measures around 10 centimeters or more in length and approximately 8 millimeters in diameter.
About 10 centimeters long.
Though this width dramatically diminishes to a mere 1 millimeter as it approaches the uterine cornu. Anatomically, the fallopian tube is beautifully segmented into 4 distinct parts, each with its own characteristics.
4 parts. Can you break those down for us, perhaps giving us a sense of their functional significance?
Absolutely. First, the interstitial portion is the innermost part, actually burrowing through the myometrium of the uterine wall to open directly into the endometrial cavity.
Inside the wall.
Right. It's the shortest at about 18 millimeters and famously the narrowest, with an internal diameter, often 1 millimeter or less, meaning only the finest surgical cannulas can pass through it during a falloscopy examination. It uniquely lacks longitudinal muscle fibers, but possesses well-developed circular fibers, suggesting a sphincteric role.
Very narrow.
Second, the isthmus is the next segment, representing about 1/3 of the tube's total length, or about 35 millimeters. It's narrow but wider than the interstitial part, with a 2 millimeter lumen. Its muscle wall contains both longitudinal and circular fibers, and it's covered by peritoneum except for a small bare area on its inferior side. It's relatively straight.
Yeah, this is okay.
Third, the ampule is the lateral widest and longest part, comprising roughly 2/3 of the tube, measuring a substantial 60 to 75 millimeters.
The longest part.
Yes. Here, the internal lining, the mucosa, is arborescent, meaning it's incredibly tree-like, with many complex folds and branches. This is the primary and crucial site where fertilization typically occurs.
Site of fertilization.
Finally, the fimbriated extremity, or infundibulum, is the funnel-shaped end, where the abdominal ostium, the opening, connects directly into the peritoneal cavity. The fimbriae themselves are finger-like projections that are highly modal and almost prehensile, meaning they can grasp, with a considerable range of movement.
Like fingers.
Pretty much. One fimbria, the ovarian fimbria, is larger and longer, and is specifically attached to the region of the ovary. This fimbria plays a vital role. At ovulation, it literally embraces the ovary, helping to pick up the released ovum and gently guide it into the ampullary portion of the tube.
Actively catches the egg.
It does.
So it's a very active, almost living pathway. What's its developmental origin and its continuity throughout the reproductive system?
Well, the fallopian tube represents the cranial or head end of the Mullerian duct, which is a key embryonic structure.
Mullerian duct origin.
Its internal lumen is continuous with the cavity of the uterus. Consequently, this continuous pathway is how both spermatozoa travel to meet the egg and how the fertilized ovum then travels back towards the uterus for implantation. This continuity is also harnessed clinically. Fluids like dyes or gases like carbon dioxide can be injected through the uterus and via the fallopian tubes into the peritoneal cavity to clinically investigate their patency, a procedure known as a dye test.
Testing if they're open.
Exactly. The fallopian tubes lie within the upper part of the broad ligaments and are covered by peritoneum, except along a thin inferior area that remains bare due to the peritoneum's reflection to form the two layers of the broad ligament.
And its blood supply and lymphatic drainage. Does its dual blood supply protect it from inflammation?
The blood supply of the fallopian tube is primarily derived from the tubal branches of the ovarian artery. However, an anastomosing branch from the uterine artery also supplies its inner part.
Two sources.
Yes, this dual blood supply arriving from opposite ends of the tube is incredibly robust and clinically significant. Unlike, say, the vermiform appendix, which often becomes gangrenous when acutely inflamed due to a single-end artery supply.
Right, the appendix.
The fallopian tube typically does not suffer gangrene, even when severely inflamed, precisely because of this reliable backup blood flow.
That's a crucial difference.
It is. The lymphatics of the fallopian tube communicate with those of the funduses of the uterus and the ovary. They drain along the infundibulopelvic ligament to the para-aortic glands, which are located near where the ovarian artery originates from the aorta, with some drainage also going to the pelvic glands.
And the layers of the tube itself, beyond the basic anatomical parts, what does their histology tell us about function?
Okay, layers. The fallopian tubes are comprised of three distinct layers: a serous layer, a muscular layer, and a mucus layer. The serous layer is simply the mesothelium of the peritoneum covering the outside. Beneath this, between the mesothelium and the muscle layer, is a well-defined subserous layer that contains numerous small blood vessels and lymphatics.
Subserous layer.
The muscular layer consists of an outer longitudinal and an intercircular layer of smooth muscle fibers. Interestingly, the circular fibers are best developed in the isthmus and gradually thin out as you approach the fimbriated extremity.
Muscle layers.
The mucous membrane, or internal lining, is famously thrown into intricate folds, or plicae. Near the isthmus, you can discern about 3 simple folds, but as you trace them laterally into the ampulla, they become incredibly complex, dividing and subdividing like branches of a tree, forming a truly arborescent pattern.
Arborescent, tree-like.
Exactly. Each plica consists of a stroma, a cellular connective tissue, somewhat similar to the endometrium covered by epithelium. The stromal blood vessels are plentiful, especially in the highly folded ampullary region. The epithelium of the mucous membrane itself consists of 3 types of cells.
3 cell types.
Yes, the most common are ciliated cells, which are either columnar or cubical. Their primary function is to generate a gentle fluid current that propels the inert ovum towards the uterus.
Moving the egg along.
Unlike sperm, the ovum lacks its own mobile power, so it relies on these cilia to guide its journey. Next in frequency are goblet-shaped cells, which are not ciliated and don't show histochemical reactions for mucin. Their function is believed to be lubricant and potentially nutritive to the ovum.
Lubricant and nutrition.
Finally, there are intermediate, or PEG cells, which are small, rod-shaped cells whose exact purpose is still being researched. It's also fascinating that histological differences in the epithelium of the fallopian tubes can be observed throughout the menstrual cycle, reflecting their hormonal responsiveness.
So given all this intricate function, how do clinicians actually test for fallopian tube patency, that they're open and functioning?
Excellent question, because tubal patency is critical for fertility. The main clinical methods used to test if the fallopian tubes are open include hysterosalpingogram, which uses X-ray dye,
HSG,
sonosalpingogram, which uses ultrasound and saline, and laparoscopic chromotubation, where dye is injected directly during minimally invasive surgery to visualize its passage.
chromotubation during lap.
Exactly. Laparoscopy is particularly valuable because it can also identify external tubal adhesions, scar tissue on the outside of the tubes, which can prevent conception even if the tube itself is technically open.
Now, let's turn our attention to the ovaries, the endocrine and reproductive powerhouses of the female body. What's their typical anatomy and outward appearance?
Okay, the ovaries. Each ovary, a truly vital organ, typically weighs between 4 to 8 grams and measures approximately 35 millimeters in length, 25 millimeters in width, and 18 millimeters in thickness.
Almond-shaped.
Yes, they're almond-shaped with a distinctive pearly gray color due to a compact outer layer called the tunica albuginea, and their surface often appears slightly corrugated or wrinkled, reflecting years of ovulatory cycles.
And how do these vital organs change throughout a woman's life? Are there significant age-related differences?
Oh, profound age-related changes, almost telling a story of a woman's reproductive journey. Before puberty, the ovaries are quite small and are located higher up near the pelvic brim.
Small and high up initially.
Right. After menopause, as hormonal activity ceases, They atrophy significantly, becoming shrunken and developing much more marked grooves and furrows on their surface. A postmenopausal ovary typically measures about 20 by 10 by 15 millimeters, with a volume of 8 milliliters or less.
Shrink quite a bit.
They do. This age-related shrinkage is a crucial clinical point. Ultrasonically, an ovary larger than 8 milliliters in a postmenopausal woman is considered a major red flag, raising significant suspicion for a neoplasm or new growth, potentially cancerous.
Big red flag if enlarged postmenopause.
Absolutely. Therefore, any palpable adnexal mass, meaning a mass near the uterus in a postmenopausal woman, must be viewed with extreme suspicion and thoroughly investigated to rule out malignancy.
So palpability is a critical diagnostic clue in older women. What about their attachments and relations within the pelvis?
Well, the ovary is attached to the back of the broad ligament by a thin mesentery called the mesovarium, which acts as a conduit for its vessels, lymphatics, and nerves.
Mesovarium again.
Laterally, the ovary is related to the ovarian fossa, a depression located below the bifurcation of the common iliac artery. And here's a critical relation for surgeons. It's also closely related to the ureter.
Ureter relation again.
Always lurking nearby, it seems. Medially, it lies very close to the fimbria of the fallopian tube, which, as we discussed, actively stretches over it around the time of ovulation to capture the egg. It's also anchored to the cornu of the uterus by the ovarian ligament. That infundibulopelvic ligament, which forms the outermost border of the broad ligament, is important because it encapsulates the main ovarian vessels, nerves, and lymphatics. While ovaries are not normally palpable during a routine bimanual examination due to their size and mobility, they can cause pain on touch, which can be an important diagnostic symptom.
Pain on palpation can be significant. And there are also some fascinating vestigial remnants related to their embryonic development.
Yes, these are intriguing remnants of the Wolffian body and duct, structures important during early fetal development. The apophoron, also known as the organ of Rosenmuller, represents the cranial or upper end of the Wolffian body.
Apophoron.
It consists of a series of small, vertical tubules found in the mesovarium and mesosalpinx, nestled between the fallopian tube above and the ovary below. Each tubule is surrounded by smooth muscle and lined by cubicle cells.
Okay.
The perophoron represents the caudal, or lower end of the Wolffian body, and similarly contains vertical tubules. It can sometimes give rise to a perovarian cyst, a type of benign cyst found near the ovary.
Perophoron, potential cyst source.
Right. Finally, the Wolffian duct itself, also known as Gartner's duct, is an imperfect, often incomplete duct that runs parallel to and just below the fallopian tube within the mesosalpinx. This duct can then travel downwards alongside the uterus to the level of the internal os, where it can enter the tissues of the cervix.
Gartner's duct.
From there, it may even run forwards to reach the anterolateral aspect of the vaginal wall, potentially extending as far down as the hymen. Clinically, this duct can sometimes form a Gartner cyst, either within the broad ligament or, quite commonly, in the vagina itself.
Gartner's cyst.
These cysts may require surgical removal if they become symptomatic, causing dyspareunia or painful intercourse or general vaginal discomfort. If located in the lower third of the vagina, a Gartner cyst can even mimic a large urethral diverticulum, which is a pouching of the urethra, underscoring the importance of careful diagnosis. The precise cellular structure and detailed histology of the ovary itself are rich topics, often explored in specialized texts on ovarian biology.
Next, let's discuss the urethra, the urinary pathway and a key player in maintaining continence. What are its dimensions and its unique epithelial lining?
Okay, the urethra. The tube that carries urine from the bladder measures about 35 millimeters in length and 5 to 6 millimeters in diameter.
Relatively short.
Yes. It travels downwards and forwards from the base of the bladder, passing behind the pubic bone, to terminate in the external nidus. Its internal lining is quite unique. It starts as squamous epithelium at the external nidus, but then transitions to transitional epithelium further within the canal, which is the same type of flexible lining found in the bladder.
Transitional like the bladder.
Exactly. Deep to this epithelium lies a vascular layer, rich in small blood vessels and connective tissue. The urethral wall itself is composed of interlongitudinal and outer circular, involuntary smooth muscle fibers, arranged in crisscross spirals.
Muscle layers.
The longitudinal fibers contract to shorten the urethra during urination, aiding in emptying, while the outer circular fibers are crucial for keeping the internal sphincter closed, thereby contributing to bladder control.
And its role in continence goes beyond just those muscle fibers, right? It seems to involve angles and pressure.
Absolutely. Continence is a multi-layered marvel of engineering. The neck of the bladder, which functions as the internal urethral sphincter, is strategically positioned above the levator ani muscles, which form the main pelvic floor support.
Above the levators.
This superior placement means that any sudden increase in abdominal pressure, such as from coughing, sneezing, or laughing, is transmitted equally to both the bladder and its neck. This equal pressure distribution is a brilliant design that helps maintain urinary continence.
Equal pressure is key.
Additionally, the bladder base forms a specific angle of about 100 degrees with the posterior urethral wall. This is known as the posterior urethrovesical angle, and this angle is also vital for preventing leakage and maintaining continence.
What are its important anatomical relations to surrounding structures, especially the vagina?
The urethra's relations are crucial for both its function and surgical safety. Posteriorly, its upper portion is somewhat loosely connected to the vagina by the vesicovaginal fascia, which allows for relatively easy surgical dissection in that area.
Loose connection higher up.
Right. However, in its lower one-third, the urethra is firmly attached to the vagina by the pubourethral ligament, requiring sharp dissection if separation is needed.
Firmly attached lower down.
Yes. This ligament plays a key role in continence by fixing the mid-urethra to the pubic bone and the lateral pelvic wall. Laterally, the urethra is surrounded by loose areolar tissue, the compressor urethrae muscle, and the superficial perineal muscles. Anteriorly, it's separated from the pubic bone by areolar tissue, creating a space for surgical access if needed.
And what about the specialized glands associated with the urethra? Are they common sites of clinical issues?
Yes, there are specific glands with clinical relevance. The external urinary meatus itself is located in the vestibule, about 2 centimeters below the clitoris, and is often partly concealed by the upper labia minora. Numerous periurethral glands surround the urethra along its course, opening via tiny ducts into its lumen.
Periurethral glands.
These are actually considered the female analogs of the prostate gland in males. More importantly, the paired periurethral glands of Skene are significant glands located alongside the floor of the urethra, opening via tiny ducts very close to the external meatus.
Skene's glands again.
When these specific glands become infected, they can form painful periurethral abscesses and cysts. The proximal urethra receives blood supply from the inferior vesical artery, while the distal urethra is supplied by the internal pudendal artery. Its veins drain into the vesical plexus and internal pudendal vein. The urethra is innervated by the internal pudendal nerve and develops from the embryonic cloaca. Given its incredibly close proximity to the vagina, the urethra is highly susceptible to infections spreading from the lower genital tract, with common culprits being N. gonorrhoeae, chlamydia trachomatis, and trichomonads, which can be identified through urethral swabs, cultures, and urine cultures.
Let's turn to the bladder, the central organ for urine storage and release. What are its fundamental anatomical features and its impressive capacity?
Okay, the bladder. It's essentially a highly elastic, smooth muscle organ, typically described as having a body and a trigone, a fixed triangular area at its base.
Body and trigone.
It's strategically positioned in the pelvis between the symphysis pubis anteriorly and the uterus posteriorly, separated from the uterus by the uterovesical peritoneum. Functionally, it's a pelvic organ designed for storage, capable of holding a substantial 500 to 600 milliliters of urine.
Holds quite a bit.
It does. As it fills and distends, it expands upwards from its fixed base at the trigone, eventually becoming palpable abdominally above the pubic bone. The bladder has a distinct apex, a base, a superior surface, and 2 inferolateral surfaces.
You mentioned the bladder neck is crucial for continence. How does its anatomy contribute to preventing accidental leakage?
Well, the neck of the bladder, which effectively functions as the internal urinary sphincter, is brilliantly positioned above the levator ani muscles. This anatomical arrangement is key. It ensures that any sudden increase in intra-abdominal pressure, say from a cough, sneeze, or strenuous activity, is transmitted equally to both the bladder and its neck.
Equal pressure again.
This equal pressure distribution is a primary mechanism for maintaining urinary continence, preventing urine from being forced out. Anteriorly, in front of the bladder, lies a potential space called the cave of Retzius, also known as the retropubic space.
Cave of Retzius.
Posteriorly, the bladder lies in close proximity to the uterus and the supravaginal portion of the cervix, but they are separated by the uterovesical pouch of peritoneum. The ureters, which carry urine from the kidneys, enter the bladder obliquely, creating a one-way valve effect to prevent backflow.
Oblique entry prevents backflow.
Exactly. The area between the 2 ureteric openings and the internal urinary sphincter forms that fixed triangular region called the trigone. The apex of the bladder is continuous with the urachus, a remnant of a fetal structure.
And it's blood supply, lymphatics, and the complex nerve supply that controls both storage and release.
Right. The bladder receives its blood supply from the superior and inferior vesical arteries, as well as the pubic branch of the inferior epigastric artery. Its venous plexus drains into the internal iliac vein, and its lymphatics drain into the internal and external iliac glands.
Okay.
The nerve supply is a sophisticated interplay between the sympathetic and parasympathetic systems. The sympathetic outflow originates from the first and second lumbar segments of the spinal cord. This system inhibits contractions of the detrusor muscle, which makes up the bladder wall and maintains contraction of the internal sphincter, thereby promoting urine storage.
Sympathetic stores urine.
Correct. Conversely, the parasympathetic outflow, stemming from spinal segments S2, S3, and S4, stimulates the detrusor muscle to contract and relaxes the internal sphincter, thus initiating urination.
Parasympathetic releases urine.
Sensory nerve fibers transmit bladder thinness signals to the central nervous system via the splanchnic nerves, which are part of the S2-S4 parasympathetic components, while somatic afferent fibers travel with sympathetic nerves via the hypogastric plexus, entering the first and second lumbar segments of the spinal cord, conveying pain and other sensations. Histologically, the bladder wall is lined by transitional epithelium, a unique type of lining that folds when empty, allowing for remarkable distension without damage.
Transitional epithelium again.
The lining membrane of the trigone is uniquely fixed to the underlying muscle wall. The muscular coat, known as the detrusor, is composed of smooth muscle, and the neck of the bladder is surrounded by circular muscle fibers, contributing to its sphincteric function.
Now onto the ureters, which our source emphasizes are delicate pathways to the bladder with significant clinical importance for every gynecologist. Why such an emphasis?
The emphasis is profound because of their inherent vulnerability during pelvic surgery. Every gynecologist must be intimately familiar with the anatomy of the pelvic portion of the ureter due to the high risk of inadvertent injury during procedures.
High risk of injury.
Very high. For instance, the ureter needs to be meticulously identified and carefully dissected during a Wertheim's hysterectomy, a radical surgery for cervical cancer. It can also run in very close relation to broad ligament cysts and myomas, increasing its susceptibility to damage.
What's its typical course and dimensions in the pelvis, which make it so vulnerable?
Well, the pelvic portion of the ureter is approximately 13 centimeters long and about 5 millimeters in diameter. Quite a delicate tube.
Thin and long.
Yeah. Its journey through the pelvis is complex. It first passes over the bifurcation of the common iliac artery and then runs downwards and forwards within the ovarian fossa, nestled deep to the peritoneum, where it then enters the true pelvis at the brim. In this region, it's notably crossed by the ovarian vessels. On the left side of the body, the mesosigmoid, a fold of peritoneum supporting the sigmoid colon, lies anterior to it. The obturator vessels and nerve lie laterally, and the hypogastric lymph nodes are also in close proximity. The ureter then continues its course downwards and forwards, always running immediately beneath the peritoneum, to which it is remarkably closely attached.
And it passes through Mackenroth's ligament, forming a ureter canal. What's the significance of that?
Yes, on the pelvic floor, the ureter performs a crucial maneuver. It pierces Mackenroth's ligament, a dense condensation of connective tissue, creating a protective passage known as the ureter canal.
Protects its movement.
Exactly. This canal is absolutely essential because the ureter must have sufficient room for its normal peristaltic movements, the wave-like contractions that propel urine, without any external pressure from surrounding structures. The ureter canal specifically shields it from such pressure. And here's a critical anatomical landmark. As it passes through the ureter canal, the ureter is famously forked by the uterine vessels. The uterine artery crosses above it, and the uterine plexus of veins passes below it.
Water under the bridge, as they say?
Precisely. After exiting this ureter canal, the ureter then courses forwards and medially to reach the bladder, maintaining a separation of 1 to 2 centimeters from the cervix.
Given its delicate nature and vulnerability, how is the ureter actually recognized during surgery amidst all the other tissues? Are there any specific tells?
It's a key surgical skill, and there are several tells. During an operation, the ureter is recognized by its characteristic pale, glistening appearance and by a fine longitudinal plexus of vessels visible on its surface.
Pale and glistening.
But most reliably, its peristaltic movements. Those tiny worm-like contractions are the definitive identifier. A surgeon might gently stroke it to elicit these movements.
Peristalsis is the key.
It really is. It can also be palpated between the finger and thumb as a firm, somewhat elastic cord that gives a characteristic snap as it slips away, a distinctive tactile sensation. While rare, Ureters can sometimes be duplicated, an anatomical variation.
Can be duplicated.
Clinically, in advanced stages of cervical cancer, particularly with extensive perimetrial involvement, the tumor can directly compress the ureter, causing a serious complication called ureteric stricture. This can lead to hydronephrosis, swelling of the kidney due to your backup, and ultimately uremia, kidney failure, making careful monitoring vital.
And what about its blood supply and the critical implications for surgical technique, particularly about preserving that supply?
The ureter has a resilient blood supply, deriving it from the common external and internal iliac arteries, in addition to a constant smaller vessel from the uterine and inferior vesical arteries.
Multiple sources.
These vessels form a longitudinal anastomosis, essentially a network of connections running up and down the ureter, which largely protects it from ischemia, lack of blood flow, even if one vessel is ligated or injured. However, damage to several small vessels simultaneously can still compromise its blood supply, leading to a vascular necrosis, tissue death, and a ureteric fistula, a very serious complication where urine leaks out.
Fistula risk.
Small branches of the renal artery also supply blood to the ureter above the pelvic brim. A critical surgical principle taught to all gynecologists is that the primary blood supply to the pelvic ureter comes from its lateral side. Therefore, ureteric dissection should ideally be performed along its medial side to preserve that crucial blood flow and prevent complications.
Dissect medially, preserve lateral supply.
Exactly.
So specific anatomical sites are particularly vulnerable to injury during pelvic surgery. Can you highlight those danger zones?
Yes, there are 4 particularly high-risk sites where the ureter is most vulnerable to injury during pelvic surgery. First, at the infundibulal pelvic ligament on the lateral pelvic wall during its clamping.
Infundibulal pelvic ligament.
Second, within the ureter canal itself, especially when the uterine vessels are being ligated or tied off.
Ureter canal.
Third, near the internal cervical os during procedures involving the cervix. And fourth, near the uterosacral ligament.
Near the os and uterosacral.
It is absolutely paramount for surgeons to identify the ureter meticulously during complex procedures like Wertheim hysterectomy, during the dissection of broad ligament tumors, and while ligating the internal iliac artery to control hemorrhage. Its lymphatics drain into the internal and external iliac glands, and its nerve supply comes from the sympathetic hypogastric and pelvic plexus and the parasympathetic sacral plexus.
Finally, in our overview of neighboring organs, let's cover the rectum and anal canal, essentially, the end of the line for the digestive tract. What's their basic anatomy and positioning in the pelvis?
Okay, the rectum is the continuation of the pelvic colon, situated deep within the pelvis at the level of the third sacral vertebra. It measures about 12 to 15 centimeters long, and then seamlessly transitions into the anal canal.
S3 level.
It is covered anteriorly and laterally by pelvic peritoneum, which forms the posterior surface of the pouch of Douglas, that important cul-de-sac we discussed earlier. Lower down, the rectum comes into close contact with the posterior vaginal wall, separated only by the rectovaginal septum, a thin fascial layer.
Rectovaginal septum separates them.
Correct. The anal canal itself is separated from the lower one-third of the posterior vaginal wall by the perineal body, a central support structure we'll delve into shortly. Posteriorly, the rectum lies intimately close to the sacrum and coccyx, cushioned by loose areolar tissue, and in relation to the middle sacral artery and the intricate pelvic nerve plexus. Laterally, you'll find the uterosacral ligaments above, the powerful levator ani muscles below, and the fat-filled ischiorectal fossa. The entire rectum is enveloped by its own connective tissue layer, the rectal fascia.
And the anal canal's specific anatomy, including its critical sphincters.
Right, the anal canal itself is quite short, measuring about 2.5 centimeters. Anteriorly, it's related to the perineal body, and posteriorly to the anacossageal body, another connective tissue structure. It features 2 crucial sphincters that work in concert to control defecation.
2 sphincters.
An involuntary internal sphincter in its upper 2/3, which is smooth muscle and unconsciously regulates continence, and a voluntary external sphincter which surrounds it below, composed of skeletal muscle and under conscious control. This external sphincter is notably encompassed by the puberectalis muscle, a part of the levator ani muscle, which forms a sling around the rectum to maintain the anorectal angle, crucial for continence.
Internal involuntary, external voluntary.
You got it.
What about the blood supply, venous drainage, lymphatics, and nerve supply for these structures? Are there any unique drainage patterns?
Yes, the drainage patterns are clinically quite significant. The rectum and anal canal receive blood supply from the superior rectal branch of the inferior mesenteric artery, as well as the middle and inferior rectal branches of the internal iliac artery.
multiple arteries again.
For venous drainage, here's a crucial distinction. The rectum and the upper one-third of the anal canal drain via the superior rectal veins directly into the portal circulation, which goes to the liver.
Upper part drains to the liver.
Right. In contrast, the lower one-third of the anal canal drains into the inferior rectal vein, which is part of the systemic circulation, returning blood directly to the heart.
Lower part drains systemically.
This distinction is vital for understanding potential routes of disease spread, particularly cancer, as liver metastases can arise via the portal system. The lymphatics of the rectum and upper one-third of the anus drain into the internal iliac and preaortic lymphatic nodes, while the lower one-third, reflecting its external origin, drains into the superficial inguinal lymph nodes.
Different lymphatic drainage, too.
Yes. For nerve supply, the rectum and upper portion of the anal canal are innervated by the autonomic pelvic plexus, which controls involuntary functions. The lower portion of the anal canal, however, is innervated by the inferior hemorrhoidal nerve, providing voluntary control and sensation. Developmentally, the rectum and upper two-thirds of the anal canal originate from the dorsal portion of the embryonic cloaca, while the lower anal canal is derived from ectoderm, an outer embryonic layer.
Now let's talk about the support system. The intricate muscles, fascia, and ligaments that tirelessly keep everything in place. Our source emphasizes that the pelvic musculature is of paramount importance in gynecology. Why is it so crucial?
It is the foundation of support. The muscles of the pelvic floor are absolutely critical. They act as a dynamic sling, providing both structural support and active control. These muscles are generally organized into three main layers: the pelvic diaphragm, the urogenital diaphragm, and the superficial muscles of the pelvic floor. Understanding each layer's contribution is key to understanding function and dysfunction.
Let's start with the deepest layer, the pelvic diaphragm, primarily formed by the levator ani muscles. It sounds like quite a complex structure.
It is. The pelvic diaphragm is largely formed by the two levator ani muscles, which are themselves intricate. Each levator ani muscle has three main divisions: the pubococcygeus, the iliococcyx, and the ischiococcygeus, also known as the coccygeus muscle.
3 parts to the levator ani.
Right. The pubococcygeus muscle originates from the posterior surface of the pubic bone and sweeps backwards, running lateral to both the vagina and the rectum, ultimately inserting into the anacoccygeal raphe, a fibrous band, and the coccyculideus. The inner fibers of this pubococcygeus, specifically those coming together posterior to the rectum, are called the puborectalis portion.
Puborectalis sling.
Exactly, the puborectalis sling. These fibers form a muscular sling that acts to lift and support the rectum, creating a critical angle for bowel continence. Some of these inner puborectalis fibers even fuse with the outer vaginal wall as they pass laterally, while others decussate, meaning they cross over between the vagina and the rectum in the area of the perineal body.
Decussate, crossover.
These crossing fibers are what divide the space between the two levator ani muscles into two crucial openings: an anterior portion, the hiatus urogenitalis, through which the urethra and vagina pass, and a posterior portion, the hiatus rectalis, for the rectum. The dimensions of that hiatus urogenitalis, that anterior opening, are critically dependent on two main factors: the inherent tone or tautness of the levator muscles and the strength of those decussating fibers of the puborectalis muscle.
And the other divisions of the levator ani, the iliococcygeus and ischiococcygeus, what are their roles?
The iliococcygeus is a fan-shaped muscle that originates from a broad area along the white line of the pelvic fascia and extends backwards and inwards to insert into the coccygus.
Iliococcygeus.
The ischiococcygeus, or cophius muscle, has a narrower origin from the ischial spine and then spreads out posteriorly to insert into the front of the coccyx. Together, all three divisions of the levator muscles form the primary pelvic diaphragm, literally supporting the entire weight of the pelvic viscera.
It supports the organs.
When they contract, they pull the rectum and vagina towards the pubic bone, effectively kinking and closing off the rectum and narrowing the vagina anteroposteriorly. This provides a crucial mechanism for continence and stability.
Protraction helps continence.
Since the origin of the levator muscle is fixed, either to bone or attached fascia, and its posterior insertion points, the anacoccygeal raphe or coccyx, are movable, contraction of the levator muscles pulls these posterior attachments towards the symphysis pubis. This property is quite remarkable as it assists the movement of internal rotation of the presenting fetal part during childbirth.
Helps rotate the baby.
It does. As uterine contractions push the baby down onto the levator ani, the muscles instinctively contract due to direct pressure. The lowest part of the fetus is then carried forwards during these contractions, and as the anterior fibers of the muscles are directed inwards and forwards, the presenting part is beautifully guided to rotate forwards and inwards, facilitating delivery.
Wow, intricate role in birth.
Both the superior and inferior surfaces of the levator muscles are covered by the pelvic fascia, which acts as a protective sheath, separating them from the cellular tissues of the pterymetrium above and from the fibrous and fatty tissues of the ischiorectal fossa below.
Moving to the second layer, the urogenital diaphragm, also called the triangular ligament. This sounds like a key support in the anterior pelvis.
It is, though notably, this layer is not as robustly developed in females as it is in males. It spans from the pubic arch anteriorly to the central point of the perineum posteriorly, and essentially consists of two layers of fascia-dense connective tissue, through which both the vagina and the urethra pass.
Two fascial layers.
The central point of the female perineum, a critical junction, lies between the vagina and the rectum. Nestled within these two fascial layers of the urogenital diaphragm lies the deep transverse perineal muscle. This muscle extends laterally on each side to reach the ramus of the pubic bone. Historically, this muscle has been challenging to dissect in anatomical specimens and often requires special histological techniques to even demonstrate. Its functional significance is largely considered dubious in females.
Deep transverse perineal, maybe not so important functionally.
Possibly less so than once thought. However, another important muscle, the striped muscle, or voluntary sphincter of the urethra, does lie between these two layers of the triangular ligament, playing a role in conscious urinary control.
Ah, the voluntary urethral sphincter is there. And what about the superficial muscles of the pelvic floor?
In this outermost layer, we identify four key muscles. The external sphincter muscle of the anus is attached anteriorly to the central point of the perineum and encircles the anus, providing voluntary control over defecation.
External anal sphincter.
The bulbospongiosus muscle, sometimes referred to as the sphincter vagina, originates from the central point of the perineum and extends along each side of the vagina, attaching anteriorly to the symphysis pubis. It effectively wraps around and lies lateral to the urethral bulb.
Bulbospongiosis.
The ischiocavernosus muscle extends on each side from the ischial tuberosity, relating closely to the crura, or roots of the clitoris, reaching it in the midline. Finally, the superficial transverse muscle of the perineum passes laterally on each side from the central point of the perineum to the pubic ramus.
Ischiocavernosus and superficial transverse.
Importantly, deep to these superficial muscles, and situated between them and the inferior layer of the triangular ligament, lie the erectile vestibular bulb and the greater vestibular glands of Bartholin, those key lubricating glands we discussed earlier.
A central pillar holding all these muscles and structures together is the perineal body. What is it, and why is it so vital?
The perineal body is truly a central pillar, a keystone structure. It's a dense fibromuscular mass that intervenes precisely between the posterior vaginal wall and the anal canal. It's pyramidal in shape, with its apex located at the junction of the middle and lower thirds of the posterior vaginal wall.
Pyramidal structure.
What makes it so vital is that it represents the convergence of all three layers of the pelvic floor muscles, with intervening fat and fibrous tissue. Superficially, originating from this central point, are the external sphincter of the anus, the bulbospongiosus, and the superficial transverse muscle of the perineum.
Superficial muscles meet there.
Deeper to this superficial layer lies the fascial layer of the urogenital diaphragm, or triangular ligament, which encloses the deep transverse muscle. And deeper still, the pelvic diaphragm is represented by those critical fibers of the levator antemuscles that decussate or cross over between the vagina and the rectum, integrating with this central point.
All three layers converge.
Exactly. Clinically, the perineal body is assessed through both inspection and by manual palpation. By placing two fingers in the vagina and flexing them laterally, with the thumb applied externally over the labia majus, clinicians can remarkably easily palpate the levator muscles and estimate the size of the hiatus urogenitalis, that anterior opening. The tone of these crucial muscles can also be estimated by asking the patient to actively contract her pelvic floor muscles, a key part of physical examination.
So the clinical significance of this entire pelvic floor musculature is enormous, particularly for common gynecological issues like prolapse or incontinence.
It is absolutely foundational. Conditions like genital prolapse, where pelvic organs descend, stress incontinence of urine, and fecal incontinence are all directly related to a breakdown in the integrity of these structures. Laxity, atonicity, or actual denervation of the pelvic floor muscles and their supporting ligaments.
Laxity, weakness, or nerve damage.
Right. For instance, denervation or nerve damage to the pelvic nerves during childbirth can significantly predispose a woman to both urinary and fecal incontinence later in life. In recent times, advancements in imaging like perineal ultrasound and MRI have revolutionized our understanding of these supportive structures and their dynamic role in maintaining uterine position and continence.
Imaging helps visualize it better.
Immensely.
Yeah.
This detailed anatomical knowledge is non-negotiable for repairing various types of prolapse and for buttressing these crucial supporting structures effectively. For example, stress incontinence of urine can often be successfully treated by surgically elevating the neck of the bladder and through mid-urethral ligamentary suspension procedures, both of which rely on precisely manipulating these muscular and fascial layers.
Beyond the muscles, there's also the intricate network of pelvic cellular tissue, often called the connective framework. What is its composition and where is it located, and how does it play a role in health and disease?
Right, this tissue is essentially loose areolar tissue, a type of connective tissue that fills the spaces between the pelvic peritoneum above and the pelvic fascia below. It's continuous with the subperitoneal connective tissue and even the loose tissue around the kidneys in the perinephric region.
Loose connective tissue.
Because this areolar tissue is so loose, when it becomes inflamed, a condition known as pelvic cellulitis, it can lead to the formation of a palpable, often tender, swelling. And due to that direct continuation between the perinephric and pelvic cellular tissues, fluid collections or effusions originating in either region can track along these planes, eventually pointing as an abscess in the other, sometimes far from the original site of infection.
Inflammation can spread easily through it.
Yes. Within the pelvis, this tissue is bounded above by the peritoneum and below by the fascia, covering the upper surface of the levator muscles. Laterally, it's bounded by the pelvic wall, primarily by the fascia covering the inner surface of the obturator internus muscle, while medially it comes into intimate contact with the uterus and the upper part of the vagina.
You mentioned the perimetrium as a specific, clinically important part of the cellular tissue. What sets it apart?
Yes, the perimetrium is that crucial portion of the pelvic cellular tissue that specifically surrounds the uterus. By definition, it's extraperitoneal, meaning it lies outside the peritoneal cavity. It's most plentiful on each side of the uterus, particularly below the level of the internal os.
Perimetrium surrounds the uterus, below the internal os.
In this region, the endopelvic fascia, which is a deeper layer of connective tissue, thickens dramatically to form the critical ligamentous supports known as Mackenroth's ligaments, or the cardinal ligaments.
Cardinal ligaments are thickenings here.
Right. Above this level, the presence of the broad ligaments significantly reduces the amount of perimetrial tissue. It's important to visualize that the level of the levator muscle, the main pelvic floor, is actually well below the cervix, often more than halfway down the vagina, so the perimetrium sits above this. The pelvic cellular tissue is typically very abundant on each side of the vagina, where it's specifically called perivaginal cellular tissue, or pericolpos.
You also made a distinction between pelvic fascia and endopelvic fascia earlier. Can you clarify that for us and how they contribute to support?
It's an important distinction for anatomical precision. The pelvic fascia consists of dense connector tissue that forms coverings over the surfaces, both above and below, of the deeper pelvic muscles, like the levator ani and the obturator internus muscles.
Pelvic fascia covers muscles.
Right. In contrast, the endopelvic fascia forms the more specific connective tissue coverings for the mobile pelvic organs themselves. The vagina, the supravaginal portion of the cervix, the uterus, the bladder, the urethra, and the rectum.
Endopelvic fascia covers organs.
Exactly. Additionally, condensed, stronger bands of this endopelvic fascia extend from these movable organs to anchor them to the back of the pubic bones, to the lateral walls of the pelvis, and to the front of the sacrum. The function of the endopelvic fascia is twofold. It acts as a conduit for blood vessels supplying the pelvic organs, and fundamentally it provides crucial support.
Support and vessel pathway.
Between the different layers of the endopelvic fascia, there are relatively bloodless spaces, which are important surgical planes to identify during vaginal plastic operations. The term pelvic cellular tissue itself should ideally be restricted to the loose cellular tissue that intervenes between the different layers of the endopelvic fascia and also lies between the peritoneum above and the true pelvic fascia below.
So specific organs have their own fascial coverings within this system, almost like individual envelopes.
Precisely. Anteriorly, the bladder is enveloped by an endopelvic fascial layer called the vesical fascia. Behind the bladder, both the vagina and the supravaginal portion of the cervix are covered by their own specific endopelvic fascial layers.
Each organ wrapped individually.
Pretty much. However, immediately behind the uterus and vagina, the peritoneum, which covers the back of the uterus and the posterior vaginal fornix, significantly reduces the amount of pelvic cellular tissue in these areas to a bare minimum, creating that very close relationship to the peritoneal cavity we discussed. Deep to the uterosacral folds of peritoneum, the endopelvic fascia is particularly plentiful and condensed to form the uterosacral ligaments.
Uterosacral ligaments formed here.
These ligaments are strong bands that pass backwards and upwards from the uterus anteriorly to reach the sacrum, lying lateral to the rectus sigmoid. The uterosacral ligaments serve a vital function. They help support the uterus and prevent it from being forced downwards by increases in intra-abdominal pressure, like during a cough or strain.
Prevent descent.
Through their inherent tone, they also tend to gently pull the cervix backwards, thereby contributing to the natural anteversion of the uterus. They contain both plain muscle fibers and a rich supply of sympathetic and parasympathetic nerves. McEnroe's ligaments, similar to uterosacral ligaments, also powerfully support the uterus and prevent its descent when intra-abdominal pressure is raised. However, they are composed almost entirely of connective tissue, containing very little smooth muscle.
It sounds like there's a specific, almost architectural design to these supports, forming a complex yet efficient system.
It's a remarkable example of bioarchitecture. One particularly elegant and critical part of the supporting mechanism for the pelvic viscera is what's described as a triradiate condensation of endopelvic fascia.
Triradiate condensation.
Imagine it like a three-spoked wheel or a hammock suspended by three strong ropes. The interior spoke is the pubocervical fascia, also known as the pubocervical ligament. The lateral spoke is McEnroe's ligament, and the posterior spoke is the uterosacral ligament.
Three spokes. Pubocervical, McEnroe's, uterosacral.
Exactly. All three of these structures literally embrace and insert into the cervix. When they are intact and healthy, they function like the strong strings of a hammock, effectively preventing the descent of the pelvic organs they support. However, if one or two of these crucial strings are torn or weakened, often during childbirth or due to chronic strain, the contents of the hammock, meaning the bladder or the uterus, can prolapse and descend, leading to significant symptoms.
The hammock analogy makes sense. And what other crucial contents are found within this complex endopelvic fascial tissue?
Well, this tissue is a bustling highway of vital structures. It contains the main uterine arteries and veins, along with the extensive venous plexus that surrounds the cervix and the lateral fornices of the vagina.
Vessels and nerves.
Lymphatics from the upper two-thirds of the vagina and from the uterus, ovaries, and fallopian tubes all pass through this pelvic cellular tissue on their way to regional lymph nodes. On each side of the uterus, there's sometimes a small, often inconstant lymphatic gland about the size of a pin's head, referred to as the gland of the perimetrium, typically located near the ureteric canal.
Gland of the perimetrium.
As we discussed earlier, the ureter itself travels through the perimetrium via the ureteric canal in an anteroposterior direction, situated about 1 centimeter lateral to the cervix on its way to the bladder. It critically passes below the level of the uterine vessels, which cross it as they run transversely through the pelvis to reach the uterus.
Ureter runs through it.
The perimetrium is also rich in sympathetic nerve ganglia and nerve fibers, forming an important network known as Frankenhauser's plexus.
Frankenhauser's plexus.
So inflammation in this area, or the spread of cancer, must have significant clinical consequences due to these dense contents and connections.
Indeed, the clinical implications are profound. In conditions like perimetritis, inflammation and thickening of the perimetrium occur. Rarely, this can form a substantial swelling, extending downwards to the fascia covering the levator muscles. Medially, it's in direct contact with the uterus and the upper part of the vagina. Laterally, it can extend out to the pelvic wall, and posteriorly, it follows the uterosacral ligaments, remaining in close relation to the rectosigmoid. Inflammation can spread widely.
Such a swelling can even track upwards out of the pelvis, reaching the subperitoneal tissues of the iliac region, and pointing as an effusion or abscess above Poupart's ligament, lateral to the great vessels. Or it can track upwards to the perinephric region around the kidney.
Can track quite far?
Yes. In advanced cases of carcinoma of the cervix, cancer cells often infiltrate this perimetrium, spreading either laterally along McEnroe's ligaments or posteriorly along the uterosacral ligaments. Clinically, infiltration of the perimetrium is a critical staging parameter, detected by assessing the mobility of the cervix and uterine body, by palpating McEnroe's ligament through the lateral fornix of the vagina, and by examining the uterosacral ligaments via rectal examination.
Key for cancer staging.
Absolutely. Furthermore, the fibrosis that can result from chronic perimetritis can cause persistent chronic pelvic pain and, more gravely, lead to ureteric obstruction, potentially damaging the kidneys. To summarize the genital organ support simply, we can think of three main levels.
3 levels of support.
Level I involves the uterosacral and cardinal ligaments, providing crucial support for the uterus and the vaginal vault. Level 2 includes the pelvic fascia and the pericolbos, which connect the vagina to a landmark called the white line on the lateral pelvic wall via the arcus tendinis. And level 3 comprises the levator ani muscles, which predominantly support the lower one-third of the vagina. This layered support system is what keeps everything in its proper place.
Let's turn our attention now to the vascular landscape, the incredibly intricate network of blood supply and drainage within the pelvis. We'll begin with the arteries, specifically the ovarian arteries.
Okay, the ovarian arteries are fascinating because they take a long journey. They arise high up from the aorta, the body's main artery, just below the level of the renal arteries that supply the kidneys.
Come from the aorta.
From there, they descend, first crossing over the ureter, then the external iliac artery, before finally entering the infundibulopelvic fold. The ovarian artery then sends crucial branches to supply the ovaries and the outer part of the fallopian tubes. It ultimately terminates by anastomosing, or connecting, with the terminal part of the uterine artery, after giving off a branch to the uterine cornu and one to the round ligament.
And the internal iliac artery, often referred to as the hypogastric artery, sounds like a truly major player in pelvic blood supply.
It is a critical artery. The internal iliac artery is one of the two main bifurcations of the common iliac artery, typically about 2 centimeters in length, a key anatomical relation. The ureter lies anterior to it, and the internal iliac vein lies posterior.
Ureter anterior to it.
This artery then divides into an anterior and a posterior branch, with the anterior branch being the primary supplier to most of the pelvic organs. In complex obstetric and gynecological surgery, severe life-threatening hemorrhage is often controlled by strategically ligating or tying off the internal iliac artery on either side.
Ligation controls bleeding.
During this potentially life-saving procedure, the crucial anterior relation of the ureter to the artery must be meticulously remembered to avoid inadvertently injuring that delicate tube.
The uterine artery itself has a very distinct and crucial course. Can you walk us through its path and how its branches supply the uterus?
The uterine artery is indeed a masterpiece of vascular engineering. It arises from the anterior trunk of the internal iliac artery. Its course begins by descending downwards and forwards until it reaches the perimetrium, where it makes a sharp turn medially towards the uterus.
Turns medially.
It typically reaches the uterus at the level of the internal outlet, where it makes another sharp right-angle turn and then ascends vertically, following a characteristic spiral course along the lateral border of the uterus all the way up to the region of the uterine cornu.
Spiral course upwards.
Here, it sends a final branch to supply the fallopian tube, and then terminates by anastomosing with the ovarian artery. This tortuosity, or winding, of the uterine artery is particularly pronounced in a non-pregnant uterus, but it remarkably straightens out and loses its winding appearance when the uterus enlarges significantly during pregnancy.
Straightens in pregnancy.
Along its vertical course, it sends numerous transverse branches directly into the myometrium. These are called the arcuate arteries. From these arcuate arteries arise a series of radial arteries, almost at right angles, which penetrate deeper into the uterine wall. These radial arteries reach the basal layers of the endometrium, where they are specifically termed the basal arteries.
Arcuate to radial to basal.
Exactly. From the basal arteries, the terminal spiral and straight arterioles of the functional endometrial layer are derived, which are shed during menstruation. Interestingly, the very midline of the uterus is the least vascular part. A significant branch, the vaginal branch at the uterine artery, arises before the main uterine artery passes vertically upwards at the internal os level.
Vaginal branch comes off early?
Yes. This branch descends through the perimetrium to reach the vagina in the region of the lateral fornix. This descending vaginal artery is of immense importance during total hysterectomy because if it's not separately clamped and ligated, it can lead to dangerous and profuse operative hemorrhage.
Critical to ligate separately.
Absolutely. The arcuate arteries that supply the cervix are sometimes collectively called the circular artery of the cervix. And from these, or from the descending vaginal branches, the anterior and posterior azygos arteries of the vagina are derived. So to recap, the uterine arteries branches include ureteric branches, the descending vaginal branch, which forms the azygos arteries, circular cervical branches, arcuate arteries, which give rise to radial, basal, and then spiral straight arteries, and its vital anastomotic connection with the ovarian artery.
And that critical, often discussed relationship between the uterine artery and the ureter, how do they cross paths, and why is this a danger zone?
This relationship is paramount for surgical safety. The uterine artery famously crosses above the ureter in the perimetrium, where it also gives off an important ureteric branch directly to the ureter. The artery runs transversely, while the ureter runs approximately anteroposteriorly through that ureteric canal of the perimetrium. This crossing point is a primary location for inadvertent ureteric injury during pelvic surgery, necessitating meticulous identification and dissection. There's also the middle sacral artery, a single vessel that originates from the very end of the aorta and descends centrally along the lumbar vertebrae and sacrum to the tip of the coccyx.
What's truly remarkable here, and our source emphasizes this, is the body's extensive network of collateral circulation. How does the body manage to ensure blood supply, even in extreme situations like massive hemorrhage?
This is where nature's engineering truly shines. The pelvic arterial vasculature boasts an incredibly extensive network of collateral connections, providing a rich anastomotic communication, meaning direct connections between all the major vessel systems.
Backup systems.
Huge backup systems. This degree of backup blood supply is profoundly important to ensure an adequate supply of oxygen and nutrients to vital organs, even in the event of major trauma, surgical injury, or other forms of vascular compromise. This is precisely why hypogastric or internal iliac artery ligation continues to be a crucial, often life-saving surgical strategy for managing massive pelvic hemorrhage when other measures have failed.
Ligation relies on collaterals.
Exactly. Bilateral hypogastric artery ligation effectively reduces the pulse pressure in the pelvis, essentially converting the high-pressure arterial flow characteristics into a more venous-like, lower-pressure system. This allows the vast network of collateral channels of circulation to step in and provide adequate blood supply to the pelvic structures, preventing tissue death.
Amazing resilience.
It really is. This remarkable function is best illustrated by documented cases of the preservation of reproductive functions and even successful pregnancies occurring after bilateral ligation of both hypogastric and ovarian arteries for uncontrolled atonic postpartum hemorrhage following delivery. It's a testament to the body's incredible ability to adapt and survive, utilizing an intricate web of connections between major arteries like the aorta, ovarian arteries, superior rectal artery, lumbar arteries, vertebral arteries, middle sacral artery, external iliac artery, and others, ensuring blood flow via various branches. For instance, the uterine artery itself acts as a collateral originating from the aorta.
And the specific arteries for the vagina, vulva, and perineum, how are these areas supplied given their external and internal roles?
The blood supply to these areas is equally intricate. Typically, the upper part of the vagina receives its blood supply from the vaginal branch of the uterine artery. This vessel reaches the lateral fornix of the vagina and then descends along the lateral vaginal wall, sending transverse branches across the vagina.
Vaginal branch supplies upper vagina.
These branches then anastomose with those from the opposite side to form the azygos arteries of the vagina, one anterior and one posterior, which run longitudinally along the vaginal walls. These small but important vessels are commonly encountered during anterior and posterior colporrhaphy operations, which are vaginal repair procedures.
Azygos arteries. In some anatomical variations, the vaginal artery may not arise directly from the uterine artery, but directly from the anterior division of the hypogastric artery, corresponding to the inferior vesical artery in males. The blood vessels supplying the perineum and the external genitalia are mainly derived from the internal pudendal artery, which is a terminal branch of the anterior division of the internal iliac artery.
Internal pudendal for perineum vulva.
Right. This artery takes a winding course. It leaves the pelvis through the greater sciatic foramen, wraps around the ischial spine, and then enters the ischiorectal fossa. The main vessel then travels forwards within the ischiorectal fossa, adjacent to the obturator internus muscle, inside a sheath called Alcock's canal.
Alcock's canal. Along its path, it gives off the inferior hemorrhoidal artery and the transverse perineal artery, which supplies the perineum and the external sphincter region. It then pierces the urogenital diaphragm and sends another transverse branch to supply the posterior part of the labia and the erectile tissue surrounding the vaginal orifice. The internal pudendal artery ultimately terminates as the dorsal artery of the clitoris, providing its vital blood supply to the clitoris and vestibule.
So we've covered the arteries. What about the veins? The pathways of return. What's particularly important about the pelvic veins?
Well, the most important feature of the pelvic veins is that they form extensive plexuses networks of interconnected veins, which are quite remarkable. The left ovarian vein drains into the left renal vein, while the right ovarian vein drains directly into the inferior vena cava.
Different drainage for left and right ovarian veins.
Yes, that's a common anatomical pattern. These plexuses are very prominent. For example, the ovarian veins within the infundibulopelvic fold form a dense network called the campaniform plexus.
Campaniform plexus.
Think of it like a complex cooling coil that surrounds the ovarian artery, playing a role in temperature regulation for the ovary. Sometimes, this plexus can become varicose, forming a varicocele, similar to the condition seen in males, and can be a cause of chronic pelvic pain.
Varicocele can cause pain.
The uterine plexus is found around the uterine artery near the uterus, and the vaginal plexus surrounds the lateral fornix of the vagina. These venous plexuses become especially well developed in the presence of large uterine fibroids and during pregnancy, where a prominent venous plexus can be observed between the base of the bladder and the uterus. The uterine plexus of veins primarily drains into the internal iliac vein.
And these venous channels can also explain unexpected sites of metastases in malignant disease. That sounds like a critical insight.
It's a fascinating, albeit sobering, insight into cancer spread. There are indeed two additional channels of venous drainage that are highly significant in explaining unexpected sites of metastases. First, there's a portal systemic anastomosis, a direct connection between the hypogastric vein, which is part of the systemic circulation, and the portal system, which drains into the liver.
Portal systemic connection.
This occurs via the middle and inferior hemorrhoidal veins, systemic, and the superior hemorrhoidal veins, portal. This connection accounts for some liver metastases observed from genital tract malignancies, bypassing the usual lymphatic routes.
Explains liver mets.
Second, there's a communication between the middle and lateral sacral and lateral lumbar venous system and the vertebral plexus, a network of veins surrounding the spine. This connection, though less common, can explain instances of vertebral and even intracranial metastases in genital tract cancers. In such patients, the lungs may actually escape metastases because the malignant cells bypass the pulmonary circulation.
Can bypass the lungs via vertebral plexus.
Correct. Furthermore, uterine veins directly communicate with the vaginal veins, which explains why vaginal metastases can occur in uterine cancer and endometriosis. The middle sacral veins, typically 2 in number, 1 on each side of the middle sacral artery, drain into the left common iliac vein. These veins are frequently encountered and must be carefully managed during procedures such as presacral neurectomy, vaginal vault sacropexy, and exoneration operations.
Now let's explore the lymphatic system, which is absolutely crucial for the body's defense and, unfortunately, for understanding the spread of disease. Our source states its importance in malignant disease is paramount. Why?
The lymphatic system and its associated glands, or nodes, are indeed of paramount importance in the context of malignant disease. This is because cancer cells frequently spread via the lymphatic pathways. For a curative effect, whether through surgical removal or radiation treatment, it is absolutely essential that all regional glands involved in the lymphatic drainage of the affected organ are identified and treated. Without this comprehensive approach, hidden microscopic spread can lead to recurrence.
Got to get all the involved nodes.
Precisely.
Let's go through the major lymphatic gland groups, starting with the inguinal glands, those in the groin area.
Okay, the inguinal glands are generally divided into 2 main groups, a horizontal group and a vertical group. The horizontal group lies superficially, parallel to Vaupart's ligament, which is located in the groin crease. The vertical group, also known as the deep femoral glands, follows the course of the saphenous and femoral veins down the leg.
Horizontal and vertical groups.
The uppermost and clinically important deep femoral gland is often called the gland of Cloquet, or the gland of Rosenmüller. This particular gland is situated beneath Vaupart's ligament in the femoral canal, nestled between Gimbernaude's ligament and the femoral vein.
Gland of Cloquet.
Additionally, there can be inconstant deep inguinal nodes found within the inguinal canal itself, along the course of the round ligament, and in the tissues of the mons veneris. Clinically, the horizontal inguinal group commonly becomes inflamed and palpable in conditions like a primary sore, e.g. from syphilis, or a Bartholin's abscess.
Often inflamed.
Importantly, there's evidence that lymphatics from the fundus of the uterus, the very top part, can travel along the round ligament and drain into this horizontal inguinal group. It's also worth noting that these glands are more likely to become involved after the appearance of late suburethral metastasis seen in advanced carcinoma of the uterine corpus, where the growth has spread downwards into the vagina via a retrograde lymphatic pathway.
Fundus can drain here.
Crucially, the inguinal glands are the primary drainage sites for the vulva and the lower one-third of the vagina. Given that the lymphatics of the medial portion of the vulva communicate directly with those of the opposite side, it's often necessary to perform a bilateral inguinal lymphadenectomy surgical removal of lymph nodes on both sides when cancer is detected in the medial portion of the vulva to ensure comprehensive treatment.
Need bilateral removal for medial vulvar cancer.
Often, yes.
And the glands of the perimetrium, also known as the hypogastric or internal iliac glands. What's their significance?
This group of glands is incredibly significant because they serve as the primary regional drainage sites for a wide array of crucial pelvic organs. The cervix, the bladder, the upper third of the vagina, and the greater part of the body, the uterus.
Primary drainage for many organs.
Yes. This means they are very frequently and extensively involved in carcinomas originating from the uterus, cervix, and vagina. These glands are most numerous immediately below the bifurcation of the common iliac artery. A specific subgroup located in the obturator fossa is often called the obturator glands. These are frequently the most obviously involved nodes in cases of cervical carcinoma, and they drain further into the external and common iliac glands.
Obturator glands often involved in cervical cancer. Then the external and common iliac glands. How do they fit into this lymphatic progression?
The external iliac glands, several in number, are situated in close relation to the external iliac artery and vein. For a surgeon to perform a truly clean dissection of these glands, it requires complete mobilization of both vessels, as some glands can lie lateral to the vessels, nestled between them and the lateral pelvic wall.
Need to mobilize vessels to clear them?
Right. These glands receive drainage from both the obturator and hypogastric glands, meaning they're the next step up in the lymphatic chain. Consequently, they are commonly involved in later stages of cervical cancer. The common iliac glands represent the upward continuation of the external and hypogastric groups. As you might expect, they are typically involved next in the progressive spread of genital tract cancers, marking a more advanced stage of disease.
External then common iliac are next steps up.
Correct.
And the sacral and lumbar groups, how do they contribute to this intricate network?
The sacral glands lie on each side of the rectum and receive lymphatics from the cervix of the uterus and from the upper third of the vagina, which have traveled backwards along the uterosacral ligaments.
Sacral glands drain cervix upper vagina via uterosacals.
Yes. Two specific groups are recognized: a lateral group lying lateral to the rectum and a medial group lying directly in front of the promontory of the sacrum. Lymphatics from these sacral glands drain either directly to the inferior lumbar group or to the common iliac group. The lumbar group of glands is further divided into an inferior group, which lies in front of the aorta below the origin of the inferior mesenteric artery, and a superior lumbar group, which lies near the origin of the ovarian arteries.
Lumbar nodes, inferior and superior.
The superior group of lumbar glands receives lymphatics from the ovaries and fallopian tubes, as well as from the inferior lumbar glands. Critically, lymphatics from the fundus of the uterus often join the ovarian lymphatics to drain into this same superior lumbar group.
Fundus also drains to superior lumbar.
All these lymphatic glands, the perimetral hypogastric, superficial inguinal, external and common iliac, sacral and lumbar, receive direct lymphatic drainage from the female generative organs and are therefore collectively known as the regional lymphatic glands of the female genitalia.
How are these regional lymph nodes assessed clinically, especially since they're not typically palpable?
Right. These regional lymph nodes are generally not palpable during a routine clinical examination, which is why imaging is so important. They can be identified on CT and MRI scans if they are enlarged to 1 centimeter or more, signaling potential involvement.
Need imaging or surgery to assess.
Exactly. During surgery, however, these glands should always be meticulously palpated, and if suspicious, removed or biopsied. The information gleaned from their assessment is absolutely crucial for accurate cancer staging and for planning appropriate post-operative therapies, such as radiotherapy, to maximize the chances of a cure.
Finally, let's turn to the nerve supply, which controls and provides sensation to these remarkable complex organs. What's the general overview of how the nervous system innervates the female pelvic region?
Well, the female genital organs, along with the bladder, receive a dual nerve supply from both the sympathetic and parasympathetic systems, working in a coordinated dance of control and sensation.
Sympathetic and parasympathetic.
The sympathetic system originates with the presacral nerve, which lies in front of the sacral promontory. This nerve plexus then divides into 2 hypogastric nerves, which descend downwards and laterally along the pelvic wall to terminate in the inferior hypogastric plexus.
Presacral to hypogastric nerves to inferior hypogastric plexus.
This plexus is a diffuse, complex network of nerves located strategically in the region of the uterosacral ligaments. Crucially, it also receives fibers from the parasympathetic system, specifically from the sacral fibers 2, 3, and 4, known as the pelvic Blanchnick nerves. From this combined inferior hypogastric plexus, a rich array of nerve fibers then branches out to supply all the pelvic organs.
So a mixed plexus.
A very important mixed plexus.
And are there specific named nerve plexuses or innervations for certain organs within this overall system?
Yes, there are important specific plexuses and innervations. For example, the cervix is densely surrounded by a rich network of nerves known as Frankenhauser's plexus.
Frankenhauser's plexus around the cervix.
The lower vagina is primarily innervated by the pudendal nerve, which provides both sensation and some motor control. The ovaries receive their nerve supply from the coeliac and renal ganglia, with these nerves following the course of the ovarian vessels directly to the ovary.
Ovaries from higher up ganglia.
Right. The external genital area, the mons, the upper and outer aspects of the labia majora, and the perineum receive innervation from the ilioinguinal nerve, derived from the L1 spinal segment, and the genital branch of the genitofemoral nerve, derived from L1 and L2. Finally, the lower vagina, the clitoris, the posterior part of the labia majora, and the perineum itself are all richly supplied by the pudendal nerve, which originates from the sacral segments S2, S3, and S4.
Pudendal nerve covers a lot down low.
It does. S2, 3, 4 keeps the pee and poop off the floor, as the saying goes.
This detailed understanding of nerve supply must have significant clinical implications, especially when it comes to managing pain, like chronic pelvic pain or severe menstrual pain.
It absolutely does. For intractable primary dysmenorrhea, severe menstrual pain that doesn't respond to conventional treatments like prostaglandin synthetase inhibitors, surgical division of the sensory nerves that accompany the sympathetic nerves can provide significant relief.
Cutting nerves for pain relief.
Procedures like presacral neurectomy, which involves surgically cutting the presacral nerve, or laparoscopic uterosacral nerve ablation, where the uterosacral ligaments are divided near their uterine attachment, are designed for this purpose. However, a surgeon must be extremely meticulous to avoid injuring the ureters, which lie in close proximity to the uterosacral ligaments during these procedures.
Ureter risk again.
Always. Another critical clinical point. The stroma, or connective tissue of the endocervix, the inner cervical canal, is rich in nerve endings, unlike the outer ectocervix. Therefore, any manipulation of the cervical canal, such as during a biopsy or IUD insertion, can trigger an unexpected vasovagal attack,
Vasovagal from cervical manipulation.
leading to a sudden drop in heart rate, severe bradycardia, or even in rare cases, cardiac arrest. For operative vaginal deliveries and procedures like episiotomy or forceps delivery, a pudendal block is often necessary to provide pain relief. This is performed by injecting a local anesthetic precisely into the pudendal nerve as it winds around the ischial spine, a clear anatomical landmark.
Pudendal block for delivery.
While less common now, presacral neurectomy has also been performed to relieve chronic pelvic pain, and specifically the pain associated with endometriosis, highlighting the direct link between nerve pathways and pain perception.
What a deep dive this has been. We've journeyed through the intricate, truly remarkable anatomy of the female genital tract and its vital neighbors. We've uncovered how each part, from the visible vulva to the hidden ureters and the foundational pelvic floor, contributes to a highly functional yet delicate integrated system. We've seen how an understanding of blood supply, lymphatic drainage, and nerve innervation isn't just academic. It's absolutely crucial for everything from diagnosing common infections to performing life-saving surgeries with precision.
And we've highlighted so many key clinical applications that underscore the depth of this knowledge. For instance, understanding the normal vaginal pH and the vital role of Döderling's bacilli is foundational for preventing common infections like vaginitis.
Right, the basics matter.
The intricate functions of cervical physiology, from actively attracting sperm and sieving out abnormal ones, to forming a protective mucus plug that prevents both conception and ascending infections, are truly remarkable examples of the body's sophisticated design.
Yeah, the cervix is amazing.
And remember how the fallopian tube's unique secretions, peristaltic movements, and the fimbria's prehensile role are all exquisitely integrated and absolutely integral to fertility.
The tube's active role.
Knowledge of lymphatic drainage is non-negotiable for precise cancer staging, for effective radiation planning, and for performing complete surgical tumor removal to achieve a cure. And let's not forget how embryonic remnants, like the Wolffian duct, can persist, manifesting as various types of cysts like Paravarian and Gardner's duct cysts.
and the surgical precautions. We really drilled down on the ureter's vulnerability during pelvic procedures, its recognition by its pale, glistening appearance, and most critically, its unique peristaltic movements, highlights the need for meticulous dissection and protection.
Absolutely. Find the ureter, protect the ureter.
The robust strength of the pelvic floor muscles and fasciae is what fundamentally holds these organs in place, so their laxity or denervation, particularly during childbirth, directly relates to conditions like prolapse and urinary or fecal incontinence.
Precisely. And the shared muscular and ligamentary supports of the bladder, rectum, and anal canal mean that laxity or damage in one area can unfortunately cascade into issues across the board. We also touched upon crucial surgical insights, like avoiding ureteric injury during procedures involving the infundibulopelvic folds or the cardinal ligaments, or even during wide approximation of the endopelvic fascia for repair.
Yeah.
Knowing precisely where the uterine artery crosses the ureter and how to confidently distinguish them is literally a life-saving skill in gynecological surgery. We also discuss how specific techniques, like subtotal hysterectomy when appropriate, can preserve sexual function and reduce the risk of vault prolapse in younger women. And maintaining a well-drained bladder during surgery minimizes the risk of bladder trauma.
Not to mention specific surgical risks, like the potential for significant venous bleeding in the cave of Retzius during a colposuspension procedure, or the frequent occurrence of rectal injuries during vaginal hysterectomy, especially when extensive adhesions have obliterated the pouch of Douglas.
Those adhesions are tricky.
The uterus's rich blood supply, with its robust collateral circulation, truly highlights the body's incredible inherent ability to adapt and survive even massive hemorrhage, as seen in cases where major vessels must be ligated.
The body's backup plan.
And recognizing the close proximity of the right fallopian tube to the appendix helps clinicians differentiate acute appendicitis from salpingitis, guiding correct treatment, while understanding mesonephric remnants helps diagnose paraovarian cysts, which can sometimes mimic more serious ovarian neoplasms and are also prone to torsion. It's a system of incredible detail, resilience, and interconnectedness.
You now possess the kind of detailed knowledge that truly elevates your understanding, allowing you to connect the dots and think like a seasoned professional in this field. Consider the incredible layers of information we've peeled back, the profound significance of a mere 1 millimeter diameter in a fallopian tube, the fascinating and vulnerable role of the squamo-columnar junction, or the strategic importance of collateral circulation in the pelvis, literally ensuring survival.
So as you reflect on this incredible anatomical masterpiece and its intricate design, consider this. How might an even deeper understanding of the developmental origins of these structures, beyond what we touched on today with the Wolffian ducts, further illuminate their vulnerabilities and strengths in health and disease?
Good question.
What might the future hold for medical interventions that work with the body's inherent elegant design rather than merely against its dysfunctions?
There's always more to explore, more questions to ask, more layers to uncover.
Until next time, keep that curiosity alive and keep diving deep into the knowledge that truly matters.